Hello everyone, this is Dr. Mohit and today we will be discussing about the Hansen's disease. Alright, so probably you must have heard about this, right? Hansen's disease, that is the leprosy. Okay, and definitely the literature goes quite extensively about this, and today we will be covering this topic in a very greater details, not just covering the dermatology part. We will be taking about all the different aspects as well. Okay, but before that I just want to give you a little bit of overview, right? So a little overview about understanding this so that you can get the best output from this lecture. So first I'll be going up with a little bit of introduction, and then I'll have the nature of the disease. Yes, how the body reacts to the offending agent, that is the Mycobacterium leprae. Okay, if you understand this part, what is going to happen is you can connect all these things, that why do you find specific features in these specific subtypes of leprosy. Okay, that is in the classification. All right, and after that, if you understand that much classification, it would be easier for you to understand the last part about it, that is the Leprae reactions. Okay, I'll be going on about this again and again, so definitely I'll make sure that it is interesting for you and me as well. Alright, so with that, let us get started with just the introduction part, but first we have to understand the nature of the Mycobacterium leprae. Yes, so what kind of temperature does he or she likes? Yes, and with that, so just by knowing, like, whether if Mycobacterium leprae likes hot conditions or the cold conditions, yes, so the clinical aspects, yes, it totally changes up. For example, if I say it likes colder environment, yes, so what is going to happen? What would you think is that, okay, fine, if it likes cold environment, definitely it will not be situated in the deeper part of the body, right? Yes, if I say, for example, give me some example of nerves, yes, which it covers up, yes, in the initial part, definitely you will not say femoral nerve. Why? Because it is quite deeply situated. Yes, and the nature of the bacteria is that it likes the cooler areas. So if I say in organ environment, it will like it would like to disrupt the ear lobules and the nose. Yes, and about the nerve, ulnar nerve, that is which is involved. There are other nerves involved as well, but this is comparatively a cooler nerve, all right, as compared to others. And the point to be remembered is it does not prefer the deeply situated nerves. Okay, these are just a few overview that I want to give you. We'll write everything about it, the incubation period which is there, yes, the generation time, the doubling time which is there, yes, so everything we should know about this. So alright, so let us get started about the Hansen's disease. Okay, so we discuss a few points from this slide, that is, it is a granulomatous disease, and yes, definitely it is infectious as well. Okay, Mycobacterium leprae, it prefers what kind of temperatures? It prefers the cooler areas, right? The cool areas. Okay, and about the organs, what organs does it like to be at? First of all, it would be the ear lobule and the nose. Okay, and about the nerve, it does not like to be situated at a very deep location, so it prefers to be on the superior part. Example is the ulnar nerve. Other nerves are involved as well, but this is just to make sure, just to give you an understanding about the nature, right, about the bacteria. Okay, how about the incubation period? Incubation period is about 2 to 5 years. Okay, 2 to 5 years. And how about the generation time? So what is the generation time? Yes, so it is a doubling period of the bacilli. Okay, so that is about 11 to 13 days. Yes, pathogenesis. So this is the phenolic glycolipid, okay, which is present on the bacillus. Okay, so that is about it. The phenolic okay, that is also the short form we use is PGL1. And how is it easy to culture this bacteria? The answer is no. Yes, so just imagine it is being cultured on the fat pad of 9-banded armadillo. Okay, that is one thing, but it is easier to stain it. That we use the Zn stain to stain it, and we can see the bacteria. Okay, all right. So that is all about the a very brief introduction about it. But now we will go on to the overview. But to make you understand the overview, I have to explain about the classifications. Okay, and what types of leprosy do we have. Okay, so for that there is something called as Ridley-Joplin classification. Okay, in all it you should have this in mind that it has some limitations as well. So usually this is a part which is not much focused upon, and that I really want to do it because I want you to have a very clear, crisp understanding about this chapter. Okay, and after this lecture is done, you should be very confident about it. Yes, so first of all, it is the determinant type and the indeterminate type. So let me give the limitations straight away. So about the Ridley-Joplin classification, right? So there are two types. Yes, so there is a determinant type and there is an indeterminate type. Okay, so all the subtypes we read about, right? From the TT till TL. Yes, we'll read about everything in a while, but I just want to give you an overview about it. That the TT and TL, these are the determinant types. Yes, and what is the indeterminate type? That is the limitations of this classification. That what is this indeterminate type is the body, the cell-mediated immunity has not yet decided what to do with it, but the bacteria is offending the body, but it has not produced any response as such, not even like a mild response, that it is just like it is there, but it is not being addressed by the immunity. Okay, that is the indeterminate type. Okay, we'll be reading about all the 6 types, yes, including the indeterminate type and all the types which are described in the Ridley-Joplin classification as well. Okay, so please keep that in mind, that is determinant type and indeterminate type. Okay, and the indeterminate types becomes the limitation about this classification. Everything I have written in the notes, nothing to be bogged down about. Let us get started about the Ridley-Joplin classification. So first we need to understand that what is the basis, right, of this classification. Yes, first thing I just want to point out a few things, that is it is about the how the disease manifests. Yes, what is the nature of the disease, about the Leprae reactions. Yes, the Lepromatous test which is there. Okay, and how about it would be about the histopathology as well. Yes, and moreover that the immunological status of the patient. In all of this, if you ask me which is the most important, I would say the immunological status. Yes, how well the patient's immunity is been responding to the offending agent. Okay, about the immunological status. So if you ask me which is the most important type, that it would be the immunological status of the patient. Yes, so if the patient starts at TT, it would be this one, this is the one which has the best response from the body. Okay, that is one thing. And if the person is not being treated well, it would just shift downwards, right? Because of the age is increasing, our immunity is decreasing. Yes, so it would just slide off from TT to LL. What is this TT, what is LL, and everything we would know about it. Now I just want to give you an overview about that. Okay, so yes, manifestation, the immunological status, the bacterial load, histopathological findings, and the Lepromatous test. This is same as the Mantoux test we did, right? So what do we do is, in this image you can see what's happening is we just take the antigen, we put it up in the superficial skin. Yes, that is the dermis, and we just see how well the body reacts. Okay, that is all about it. Now let us come about these. Yes, so the actual classification, that is in the Ridley-Joplin one. So the above ones you can see, these are the determinant type, and the one in the bottom, these are the indeterminate type. That is only one. Okay, usually I've seen, like, even myself, when I read this in the first time, I did not understood just the way I'm explaining you. Yes, so it is very important to have the clear-cut idea about what is all this classification about. Okay, so once we know this, we can have a very good grip at this topic, which is very important. Yes, which is very important, and that is the reason we are going on to so many details, and we are using so much time and spending so much time on it. Okay, so how about the TT type? Yes, so it is TT, the full form is tuberculoid type of leprosy, and the next one is BT, it's borderline tuberculoid, and this is the borderline type. BL, it is borderline lepromatous, and over here it is lepromatous leprosy, that is the polar type. So over here is TT, over here it is LL, and at the bottom is BB, okay, that is the borderline one. Over here you see, you go one in the left towards TT, it becomes BT, and toward about the borderline one, you go towards the right, it becomes BL, that is a borderline lepromatous. Okay, alright. So far it is pretty easy, nothing much complicated. But now we understand about the cell-mediated immunity. Yes, so I already told you that the TT has the best immunity. Yes, so the patient would usually, they would self-heal in the TT type. Okay, whereas in the LL type, the whole story is different. We'll see about the images as well. Yes, and what are the manifestations about everything. All these individual will be reading in a while, but just to give you an overview, that is the tubercular type, that is the most stable one, okay, and the LL type is also the most stable one, okay, and the one in the middle, the BT, BB and BL, these are the unstable forms. Okay, so as you go from left to right, the cell mediated immunity is decreasing. Okay, alright, so that is all about it. And now let us get started with the overview. So till now, whatever I spoke to you, right, whatever I spoke to you, it was just to make you understand about these names, okay, about these names, because I need them to give you an overview about this disease. So far this is what I wanted to make you understand. Okay, fine. So the next 10 minutes about this single page, this will decide how well you can understand the topic. I will repeat this single page about 3 times. Okay, first I will explain you, then we will make the notes, and then we will revise it again. Okay, so I just want you to get this single page very crisp, clear for your whole lifetime. Okay, if you know this topic well and good, it is a revision for you. If not, then this is the final time we read this topic. Okay, as I told you that the disease, the offending agent, right, that is a Mycobacterium leprae. What it is doing is, it is invading into the body, and the body is reacting in a certain way. How would the body react? It could either be with the T cells, or either it could be with B cells. Yes, T cell immunity or B cell mediated immunity. So if it is T cell mediated immunity, the T helper 1, the TH1 will be responsible for it. Yes, and if it is the B cell mediated immunity, it would be the T helper 2. Okay, fine. This is one thing I want you to clearly understand, that there are 2 aspects, the T cell and the B cell. Okay, very clear. I will come back to this point again. The TT type, yes, so the TT type which is there over here, I am mentioning about this. Okay, the TT type, what I told you, that it has the best immunity. The person has the best immunity, okay, in the tubercular type. So if it has a TT type, okay, so what's going to happen is, this has the best immunity. We just write down the notes as well. Okay, so in the TT type, the T cell, it will be involved. Yes, the T cell, it will be involved, and the T cell, these are the ones who are most efficient. Okay, the T cells are the ones who are most efficient in it. Okay, and in the T cell, this is the TH1. Yes, we are talking about. So if it could really contain the whole bacteria, so there would be granuloma formation. Okay, there would be granuloma formation in it. Yes, the tubercular granuloma we would see. Okay, that is the reason. Yes, in the granuloma, what do you think could be the histopathological finding? Do you think there will be a lot of bacillus? If a patient of TT comes to me and I do histopathological finding, what do you think? Will I find a lot of bacilli in it or very less? Tell me this. The answer is, if what topic I started this with, it is TT, it has a good immunity, and because of that, what's happening is the body is able to contain it, right? So there will be very less bacilli. That is the reason we say that the TT type is paucibacillary. Okay, TT type is paucibacillary. You see right here. It is paucibacillary. Paucibacillary. What does it pauci means? Pauci means less. Bacillary means less bacilli. Okay. Alright. Less bacilli. Okay, so we are done with one point, that is the TT part. We are done with the one spectrum of it, that is the left part. Yes, the one which has the good immunity. Now let us go on to the totally opposite one, that is the Lepromatous Leprosy, which has the worst immunity. Okay, and why do I say it has the worst immunity? And the clinical features are totally different. Why it is different? Because in it we see the T cell immunity is absent. It is T cell immunity is absent, yes, in it. So you see, T cell immunity is absent. Okay, if I say that the T cell immunity is absent, do you think there will be granular formation? Do you think that there is granuloma formation? No. If there is no T cell immunity in it, yes, so what is going to happen? I told you that T cells are the best ones. T cells are the best ones to contain them. That is the reason we were having the paucibacillary one, yes, in the TT one. But over here, I am telling that the T cell is absent. So the disease would manifest in its best form. You would see everything. The patient, the body would be destroyed. Yes, the manifestations would be so severe. Okay, so if there are no T cells, then there are what? There are B cells. B cells are macrophages. We would see macrophages would do everything in their power to do it, but they are incompetent to contain the bacilli. Okay, so what do you think it would be? It would be a paucibacillary or multibacillary? It would be multibacillary. Yes, because the body is not able to do anything. Yes, it is not competent enough to contain the bacteria. Okay, this one point you got it very clear. Yes, so that is the reason it is multibacillary. Okay, that is one point I want you to take this from this lecture, that is this one page. If you just get this one page correct, and definitely there's no doubt that this lecture you will understand everything about it. I promise you that. Okay, so the macrophages, we are talking about macrophages in the B cell type. So what's happening over here is the macrophage is trying to eat the bacilli. That is what they do, right? They are the scavengers. They are trying to eat the bacilli, but what is happening is they end up swelling. They end up in a swollen situation. Yes, so that is why they are called as what? The very specific name given to it, that is the foam cells. We have the images about that as well, and there is a very beautiful mechanism that how does this happen, but we don't need that mechanism. We only need the starting and ending part, that is we find the foam cells. Okay, all right, so now till now we did TT and LL type. Yes, and in LL type we see without the treatment. Yes, so what's going to happen is now we are connecting the points that we read about TT and LL clinically. Okay, what do you think without the treatment, the TT type? Yes, so as time goes, slowly it would progress to LL. Yes, so because the decrease in immunity, it would progress to the LL form. Okay, what do you think about the granuloma? Tell me this point. So if you understood till now, you will be able to put the arrows correctly. There would be either increasing or decreasing foam cells, either would be increasing or decreasing. Yes, okay. So I hope you are along with me and you are getting the answers right. So we are talking about the LL form in which the immunity is been decreasing. Yes, from TT you go to LL, immunity is decreasing. What's going to happen to the tuberculoid granuloma? Will they increase or decrease? Okay, the tuberculoid granuloma, it would decrease, right? Okay, it would decrease. How? Why? We'll come to that. How about the foam cells? Foam cells increase or decrease? Foam cells would increase. Okay, Fine. So now I'll revise the whole thing quickly again. So but I just hope that this part is very clear to you, because if you understood this, you would understand this part very clearly. But before this, I just want to make a quick summary about this as this initial part of this page. Okay. So we are talking about the overview about Hansen's disease, and there are two aspects about it, that is the Th1, that is the T cell and the B cell. If T cells are involved, that is the 𝗵𝗵𝗴𝗺, and if there are B cells involved, that is the Th2. And in the first one, yes, that is if the patient is having a TT type of leprosy, yes, in it what is going to happen, that is the T cell are the one who will be responsible for it, and these are the ones who are the most competent one. Okay, that is the reason the body is competent enough to contain the bacteria. So what's going to happen in clinically, if we take the histopathological slide, what's going to happen, we'll see the paucibacillary one, that is there are less bacilli in it, that is the paucibacillary, that is less bacilli in it. Because why? Because it is because of the Th1, they are very competent enough to contain the bacteria. Okay, that is one thing. And how about the other one, that is the B cell type? Yes, we go on, we take the next example about it, that is the LL type. In LL type, what's happening is, because the body is not competent enough to contain the bacteria, and if the T cells are absent, so what's going to kick in is the B cells would kick in. Yes, that is the 𝗵𝗵𝗴𝗺 ones. The macrophages, we know the macrophages would do everything in their power to contain the bacteria, but what's going to happen is it is not able to do that. Why? The reason being that they would just go try to eat up the bacteria. What's going to happen is they're just going to swell up. Yes, and what these swollen cells are called, these are called as foam cells. Okay, fine, these are the foam cells. Okay, and how about the, if you take up some bacilli, if you take up a histopathological slide, so what could you see is, we could see the multibacillary one. Alright, so on the other hand, we had paucibacillary, on this side we have the multibacillary one. Okay, Th1, Th2, T cell, B cell, and on the other side, that is the LL type, you would see the macrophages swollen up, we have the foam cells. Okay, now you come to this point, that is about the granuloma. Okay, if you understand the whole thing, we did it 2 times, one time explanation, one time a quick revision about it. So how about the tuberculoid granuloma? Tuberculoid granuloma in the LL type would be more or less, it would be less, because tuberculoid granuloma, it was caused because of the T cells. T cells are less, T cells are absent in the LL type. Okay, how about the foam cells? They are more in the LL type. Okay, so that is the reason it would be more, because there are these incompetent macrophages. Okay, if you understood this much part, yes, I know I'm repeating these topics again and again, because I want to explain you this topic very crystal clearly. Okay, especially this part. So now we see about the after the medical intervention, right? So we'll understand about the Leprae reaction type 1, type 2. Okay, what is it? That for example, a patient who has a BT or BB, right? Okay, fine, these are the ones who come up to you and we give treatment to them. Okay, so what's going to happen? The immunity of the body will increase. Okay, so if the immunity of the body increases, yes, so the body has a good stand to fight to the offending agent, that is a Mycobacterium leprae. Okay, so if the T cells are being involved in it, so it will be type 1 Leprae reaction. Okay, and how about the next one, that is if the B cells are involved, yes, and after giving the treatment, the B cells are involved. Yes, so in the B cells were involved in which type of leprosy? It was the LL type. Yes, LL type. Okay, in LL type, if we give treatment, the immunity improves. So what reaction is the body following up? It is the type 2 Leprae reaction. Okay, type 1, type 2, their clinical manifestations are totally different. When we have a complete comparison, you will understand the intricacies and the details, and it is very beautiful, the way this part, that is the T cell granuloma part which is there, yes, and the foam cell part which is there, and these two things combine, and they form a very beautiful concepts here. So what I'll be doing is, at the very end, I have made a table about it, so we'll be discussing all the details with all the photographs and all the clinical findings, correlations, everything there. All right, so but one thing over here is that the TT type is not mentioned. Yes, TT and LL. Yes, they don't specifically show any reaction. Yes, why? Because they are stable type. Okay, they are the stable type ones. All right. So let us go on to the types of leprosy which is there. We will start from the indeterminate type and go to the determinate type. Okay. How about the indeterminate type? So what did I tell you before was indeterminate type is the one where the body has no idea what to do. So that is what I have written here. Yet not decided what to do. Yes, that is the thing, right? So do you think there would be manifestations, clinical manifestations? Yes or no? Yes, obviously, right? That is what we see. We see some solitary, ill-defined nodules which are hypopigmented. Okay, it could be macules or patch, right? So let us just complete our notes that these are the solitary nodules. Yes, which are ill-defined. Yes, and these are hypopigmented. So hypopigmented, we'll understand more about it. Why it is? Why is it hypopigmented? Okay. And also about the hypopigmented patches, when we were doing about the fungi, right? The cutaneous fungus infection, right? We read so much about. I also gave you 3 clinical scenarios where the hypopigmented patch. This is the topic we spoke a lot about. I'll discuss that again in this video as well. Okay, how about the sensations? Do you think the sensations would be affected or not? See, please make sure, like, when I'm asking you any questions, right? So you have to understand, if I'm asking any questions, definitely I must have given a hint in the previous part. So we are talking about the indeterminate type. You see, the body has not yet decided what to do. So what's going to happen is the sensations would be normal. Okay, the sensations are normal if you touch these lesions over here. Yes, so definitely it is very easy to get confused with preteractive vesicular, right? Okay, but definitely the preteractive vesicular has its own classical findings which we cannot see in this one, but the sensation part, both are normal. Yes, in this and that as well. So this is a common point. We discussed about this already. Sensations are normal. Okay, how about the scaling? Do you think do you see any scale, collarate of scale appearance? Do you see some central clearing, peripheral scaling, anything like that? Nothing, right? So scalings are absent. Okay, presence of scale are a characteristic. Presence of scale are a characteristic features of what? Preteractive vesicular, right? So we see that over there. Scales are absent. Scales are absent. How about the pruritus? Negative, absent as well. Okay, nerves. How about the nerves? Even though they are hypopigmented patches, the nerves are not enlarged. Okay, nerves are not enlarged, so we cannot have a very clear cut demarcation about the nerves. Okay, this is all about the indeterminate type. Okay, because the body, it is still not much progress. So this is all about that. But we need to know, because to keep this as a differential diagnosis whenever we see a hypopigmented patch. Okay, all right. Coming on to the next one, that is the first. Now we are starting up with all of these, right? So we will go about with TT, BT, BB, BL and BLL. Okay, one by one we'll see all the different aspects about it. So TT, so any point do you remember when we discuss about TT? Is not the first time talking about it. So before, when I give you an introduction, so what did I say you? What that was? How about this? Can you comment about cell-mediated immunity? Is it very worse or it is very good? What is it? So it is cell-mediated immunity is extremely good, right? That is the reason the body gives an optimum response. The T cell, right? We when we did about our overview, the T cell, right? The Th1, which gives an optimum response, and it could control and localize the infection. And that is the reason we call it as what? Multibacillary or paucibacillary. We call it paucibacillary, right? That is one thing we should know. That is Over here, yes, we would have a granuloma formation, yes, okay, that is a very classical thing. So what's going to happen over here is, so these points are very important to understand the TT part, okay. These 4 lines, if you understand, you are all good to go. What actually happening over here is, so there is granuloma formation, okay, granuloma formation is there, okay. So because of that, there is nerve compression, So if there is nerve compression, so what can you comment about the sensation? Sensation would be present, absent, or what do you think? Sensations. Sensation, there will be loss of sensation. Yes, now you see, you just compare with this one. Okay. Over here I said that sensations are normal. Over here I am telling that the sensations are gone. Loss of sensation and sweat as well. Okay. Anhidrosis you would see. Okay. How about the patches? What do you think will be the presentation of patches? So do you think there will be patches? Yes or no? Yes. How many? About 1, 2, 3 patches. Yes, 1, 2, 3. There would be hypopigmented patches. How many we would see? About 1, 2, 3 patches we would see. Okay. Over here, that is all about the findings which are there, right? So now if you want to describe the lesion more properly, what do you think? Okay, fine. Now I have just zoomed into the image here. So can you comment about the findings, in here? I know, like, even though you are reading this topic for the first time, but definitely you can say, right, can you describe this? Okay, that would be, you see right here, it is the periphery are a bit elevated, yes, and at the bottom you see it is at the same level as the skin. So what it is forming is, something like this. Yes, something like this structure has been formed. Okay, so this is as equivalent to something like this, Alright, so this is a saucer, yes, this is an illustration of the saucer, and the cup which is there, this is at the bottom we use, yes, so we use it to hold the teacup. Alright, that is that. Okay, alright, so this is been the classical name for this is a saucer which is a right way up. Yes, right way up, it is not inverted. Okay, it is not inverted, it is right way up, it is just like this. Okay, and this is the illustration about that. Okay, so this is a saucer which is a right way up. Okay, fine. That is a very classical I would say sentence about the TT type. Yes, that is the lesions which are there, they are saucer which are right way up, right way up. Alright, so definitely we can see over here there are raised margins and well defined borders. Okay, so you can you see the raised margins, the defined, the borders are well defined. Okay, very simple. How about this? This is the granuloma we see, right, the horseshoe shaped granuloma which is there, and over here we have the multinucleate giant cells. Okay, very classical for this disease. Okay, how about the next one? So we just got completed with the intermediate type and the TT type. Okay, so TT I'll just revise once again, that is, in TT the body is having optimum response. This is the first thing you should remember about it. Optimum response, granuloma will be formed. Okay, the nerves will be compressed, sensation would be lost, hypopigmented would be seen. How many? 1, 2, 3 would be seen. Okay, we will see a granuloma, multinucleate, right? Granuloma we would see, multinucleated giant cells we would see. Okay, how about the patches? Can you comment about the patches? This would be saucer right way up appearance in which the borders are well defined. Okay, as simple as that. So now we are done with intermediate type and the TT type. Okay, now because we just got introduced to this word, that is a hypopigmented patch. And if you remember, in our previous discussion about the fungal infections, I also told you about one clinical scenario that happened in our dispensary when I was with my dad, right? So that was the example. Yes, when we saw a couple, they came up with a hyperpigmented patch on the shin, right? That story. Okay, fine. So I'll not repeat that again. Yes, over here, because we went to extensive details about it. So it is just a correlation with that. And the same thing, I want to take this opportunity and revise this part. This is the same slide I used earlier as well. So you might be familiar with this. Okay, so how to differentiate a hypopigmented patch? So what are the differential diagnoses we should have? This is not a part of leprosy, but I just want to reimburse that fact, that what we learned earlier should not be forgotten. You should not, forget now. Everything is about, how well we can compress the topic and how well you can understand the patient, the clinical scenario which are there. Okay. So write up what I did was I made up 3 scenarios. Okay. 3 scenarios right here. So what we can do is we can just, okay, let me ask you some questions. Okay. So prolonged fever, the person is from endemic area and the scratch sign is positive and the sensations are normal. Okay. Okay. This is PKLD, right? This is PKLD. Post Kala-Azar dermal leishmaniasis. Yes. Post Kala-Azar dermal leishmaniasis. Okay. All right. How about this? How about the second one? Yes. So sensations are reduced. Yes. And even in the sensation, yes, we have temperature one. Temperature is the first sensation to be lost. Okay, so what is this? Sensations are lost. First, when you see this word like sensations are lost, what the only thing you should have in your mind is Hansen's disease. Okay, alright, that is important. How about the next one? There is central clearing, scratch sign is positive, asymptomatic patient and peripheral scaling is seen. Tell me, what is this, ladies and gentlemen? Okay. Do you guys remember what is scratch sign, or do I need to make you revise this topic? Scratch sign, yes. 𝗵𝗵𝗿𝗺, yes. So we also read so much about this. So what's happening is the lesions. When we ask the patient, just to scratch on it, the lesions become more pronounced. Okay, the lesions become more pronounced. That is what it means of having a scratch sign positive. In which conditions do we have this? This is pityriasis versicolor, right? In pityriasis okay, fine. Yes, so that is all about this, how to differentiate between a hyperpigmented patch. Okay, so not a big deal, very simple thing to remember. Okay, so you just remember these 3 cases, your life is set, nothing to worry about, no questions will ever go wrong. Okay, so if you remember, let me take you back right here. This is done, okay, right? This is done, and now we're going to start with the borderline tuberculoid. Okay, so the indeterminate type is done and the TD type is done. Okay, and we'll learn about how to differentiate between the hypopigmented patch. Now we'll start about the borderline tuberculoid, BT type. Okay, fine. Borderline tuberculoid, we have it right here. Okay, over here there are a few things which are very, very peculiar about it that you should know. Is that first of all, this is not an early version of it. Okay, so if you remember that thing very clearly, the 5 types, this was somewhere in the second position. So what do you think about the patches? Do you think there are no patches or there will be patches? Obviously there will be patches. The hypopigmented patch I'm talking about, they are gonna be there. But the thing is, how many? In the earlier one we wrote about how many patches did we write? We write about 1, 2, 3 patches. But over here the number of patches are increased. They are about 3 to 10 lesions. Okay, 3 to 10 patches are there. Okay, and also one very characteristic finding is that there is only not one single lesion, there would be on the periphery also we would find some, and there is a very characteristic name which is given to it, that is the satellite lesions are there. Okay, all right, that is all about the borderline tuberculoid. So we'll just go and see the images. You see over here, yes, you see this patch, yes, you see this. Okay, all right, and how about the histopathological finding? You see, in the borderline leprosy we have this right over here. Yes, we see this multinucleated giant cell, but the thing over here is it has a clear vacuole. Okay, this is very characteristic about the BT type, and about the previous one, let us just compare. You see over here, at the periphery we are seeing a very nice horseshoe shape, right here we see this. Okay, fine. So BT type and TT type, we should always remember this part. Okay, with fine cytoplasmic vacuolization. Okay, this point is very important with the histopathological findings. How about the mid borderline, that is the BB type? Okay, what do you think about the lesions? Lesions would increase or decrease? Increase, right? The lesions would increase. That is, this one is the one in the very center, TT, BT and BB type. Okay, from now the things would get worsen up more and more, because the cell mediated immunity is decreasing and the disease will be more pronounced. Yes, now we will see the disease in its best form. Okay, polymorphic regions, about 10 to 30 lesions would be visible. Yes, and it is geographical appearance, a map like appearance. Right here you see, it feels like there are islands, about 10 to 30 islands which are there, but still they are countable. They are still countable, like you can count. But in the next one, what's going to happen is that they're going to be so much, they're going to be so many that it is difficult to take and count about it. Okay, but still it is in the countable range. Okay, as you can see, the quite, see the involvements, and we will learn, when we learn about Leprae reaction 1 and 2, why they are red. Some would have a crust, but some are very erythematous. Why is it happening? Is it because of Leprae reaction 1 or 2? This answer, we keep these points in our head. I will come back to it when we discuss about the two types of reactions which are there. Okay, the redness means the body is actively trying to manage the condition. Okay, all right, so we go on to that. They are the geographical map like appearance. Yes, and about this because this is a BB type. Yes, so it has the features of the both either sides. Okay, so that is the reason it has inverted saucer shape appearance. Okay, let me write that, inverted saucer shape appearance, or a punched out appearance. Okay, at the center we would see a clear skin, and in this one you can see in this lesion you can see little bit in this lesion as well. So this lesion is over here you can see. Okay, how about this patient? Yes, you see right here the central clearing which is visible. Okay, all right, so not in all the lesions we can see, but definitely in this we can clearly see. Okay, so that is all about the findings about the mid borderline, that is the BB type. Can you comment about the sensations? Can you comment about sensation? What do you think? What do you think about the sensation? How would they be? See the sensations, right? So in the TT type, the sensations were what? Normal, present, absent, not there. What it was? The sensations were normal. In LL type, what do you think sensations would be? Yes, LL type sensations would be what? Yeah, so this is the point we have to understand, right? So in sensation it improves. Sensations are improving. Yes, why? Why the sensations are improving even though the disease the progression is getting worse and worse and worse. But the reason is the thickness in the nerves, the thickness in the nerves are slowly decreasing. Why is it slowly decreasing? See, please remember when I told you what was the reason for having the sensation, loss of sensation, and the sweat glands being affected was there was granuloma formation. Because of the granuloma formation, it was compressing the nerves. Because it was compressing the nerves, yes, so there was loss of sensations, yes, and if there were loss of sensations, yes, so that is the reason, also reason there was hypopigmented patch. Okay, do you remember these 4 stations? I will go back to that again and I'll make sure you remember everything today. Okay, so granuloma formation, nerve compression, loss of sensation, hypopigmented patch. Okay, fine. So now if I am telling you that because the disease is progressing further, what do you think? In the TT type, yes, what was happening? There was more granuloma. Now I am telling, because the disease is progressing further towards the right side, that is towards the LL side. What do you think would happen to the granuloma? Comment on this. What do you think would happen on the granuloma? Please comment on this. Granuloma will decrease. Yes, are you getting my point? Granuloma will decrease. How about the foam cell? How about the macrophages? The B cell immunity, the Th2 type, will it kick in or not? Yes, that is the one. That is the guy who's going to kick in, right? And then the T cells, they would be absent. Yes, comparatively less. So that is the reason, when the disease progresses from the TT type to the LL type, and in this case, there is the BB type we are talking about. Yes, the mid borderline which we are talking about. So what's going to happen is the granuloma would be less. That is the reason. Yes, the compression would be less and the sensation improves. Okay, so I hope I made myself very crystal clear. There's no doubt about it. Okay, decrease in granuloma and foam cells are increased. So foam cells, what are these? These are what? Macrophages, right? These are macrophages. Fine. These are the granuloma would decrease. Fine. How about the next one? That is borderline lepromatous, BL type. Okay, so this is the second last one we read about. This is the second last one. Okay, what do you think? The lesions would be numerous. The nerve involvement is numerous. The lesions are numerous. It's quite well pronounced. Yes, so it is just one stage away from the Lepromatous Leprae, which is the next one. How about the symmetry? Could you comment about the symmetry? Symmetry. It is asymmetrical. Yes. Okay, they're almost asymmetrical. And sensations, what do you think about the sensations? Yes, so the same concept, it would continue. We continue about the same concept, that is sensations would return to normal. You see, did you get it? All the time we spent over here to understand this, the same goes over here, that is sensation return to normal. Even though the disease is progressing towards the worst stage, that is from the next stage would be LL type, but the sensations are normal. Are you getting the contrast in it? Yes. Why? Only good doctors, they would know, like why it is actually happening is because the nerve thickening is less, the granulomas are less, the compression is less. Okay. Alright, we go on to the last part, that is a Lepromatous Leprosy. Okay, so this is where we see everything, the disease in its whole best form, what all it can do, it has done in this stage, that is Lepromatous Leprosy. Okay, fine, let us get started. How do you think about the involvement? Could you comment on the symmetry? Yes, it is symmetrical involvement. Okay, and the nerves, what do you think about thickening of nerves? Yes, and the skin, definitely there is quite an extensive involvement, right? So, and the bacteria, right, it would invade the nerves as well. So this, you can see, it is a TS of a nerve. It's a TS of a nerve, and you can see, yes, there is quite a bit of invasion here. Fine. Okay. All right. And how can you comment about the foam cells? So definitely my students, they would know this point very clearly because I've been banging my head about it for quite some time. This is which TH1? This is TH2, right? Okay, TH2. This is the first thing we wrote when we did the overview of the whole thing. Okay, overview of Hansen's disease. Okay, the TH2 type. The foam cells are visible. Okay, what are the exclusive features about it? Tell me. Exclusive features would be they are perfectly symmetrical, no granuloma formation. Yes, no granuloma formation. Why? Because it is the B cell immunity, right? It is not about T. If it was T, there would be granuloma. It is B. There is no granuloma. Foam cells are visible. Macrophages are swollen up. Okay, that story we did. This is what it connects here. Everything I taught you till now, it is for this moment. Okay, no granuloma formation, no nerve compression. Okay, sensations and sweating. Tell me, can you comment on this? Sensations and sweating. What do you think about this? They are normal. If you just got that one page clear, it is very easy to answer this. Otherwise, it is just difficult to understand this. Okay, fine. They are normal. Okay, because of this, yes. So what would happen is there would be something known as peripheral neuropathy. Okay, peripheral neuropathy. Alright, so because of this, what's going to happen, that there's going to be something known as glove and stock anesthesia, right? Glove and stocking anesthesia. Glove and stocking anesthesia, alright? What do you think about the earliest manifestation? Okay, so let me give you that one overview, right, which I gave you in the very first one, the first page of our discussion, first page of our notes. Yes, so let me just write that down so that this could ring a bell in your head, right? What was the nature of this bacteria? That it liked cold areas. If it liked cold areas, I told you that this would have the manifestation, right? So can you connect them? Where do you think there would be earliest sign of Lepromatous leprosy? Where do you think? It would be the nasal stuffiness. The nasal stuffiness, yes, and the epistaxis. Okay, that is the point. Nasal stuffiness. So if now give it a thought, right? If some disease is having an earliest manifestations of nasal stuffiness and it also has epistaxis as the earliest sign, do you think it is a problem for the community, that this could cause a mayhem in the community, right? If the person has leprosy, yes, the lesions are active, yes, and we'll down the line when we read about the histopathology part, we will know that if we how to identify active and inactive lesion. Yes, we would see that as well. But for now, active lesions, having an epistaxis, it would just keep on spreading. It will cause a mayhem in the community, right? That this becomes a main source of infection in the community. Did you get it? See, it is an earliest feature, and this itself is a mayhem, causing a mayhem in the community, right? This is such a dangerous situation to be in. Okay. What about all these points are very characteristic about the LL type, okay. That is, we have something known as Leonine Facies. Yes, this is the lion-like faces, okay. Yes, there is a lion-like faces which are there, okay. As you can see over here, this image you can see, and this image, okay. The nasal part, you see there is absolute destruction of the nasal, there is nasal septum perforation, absolute destruction over here. Fine, okay. We go to the next part, we will come to the nasal part once again. How about the next one? Over here there is something called as madarosis. So you should know this vocabulary. It is nothing fancy, it's just the name is fancy so much that what it means is there is loss of eyebrow and eyelashes, okay. You see all these patients, no, absent, okay. All right, so the third image which I kept, this is the one which clearly shows it about the madarosis, okay. The Leonine Facies madarosis, this is about the madarosis, that is loss of the eyebrows and the eyelashes, okay. Simple as that. Can you comment about the earlobe? Yes, can you comment about the earlobe? Yes. So now let us see about the histopathological findings. Yes, so what do we actually see in them? Okay, there is something called as a clearing zone, okay. Why? Because of one thing, that it does not involve the dermis, okay. The dermis is not involved. Because of this one point, we can see something known as the clearing zone. Yes, we see clearing zone, and in the clearing zone it is called as the Grenz zone. Okay, did you get this point very clearly? Because I took it the other way around, because I feel that this is the best explanation for it, okay. Dermis is not involved, that is the reason there is some existence of something called as clearing zone. Yes, in it, that is what is the Grenz zone, okay. These three vocabularies, you know it now. The foam cells of dermal histiocytes, they are full of Leprabacilli, okay. Now you just remember that point that I told you, that in the LL, because there are a lot of what, the B cells, yes, the B cell mediated immunity which is there, that is the macrophages are there. What are the macrophages are doing is they are eating up the bacilli, right? But are they able to do it efficiently? No. But will we find them histopathologically? Yes. So what are the cells, we found in this condition, that is the LL type? What it was? It was the foam cells, okay. These are the foam cells. This concept we discussed earlier as well, so this is a connection to that, okay. So I hope it is very, very clear. Let me repeat that once again. Macrophages, yes, in the B cell, macrophages, foam cell, LL type, we see something called as the Grenz zone, because there is central clearing, okay. All right, and because the dermis is not involved, we see something like a clearance zone, which is also called as the Grenz zone, okay. These 6-7 vocabularies, if you understood, you have understood everything very crystal clearly. Okay, fine. So we see over here, we see this is the Grenz zone, yes, which is where there is no infiltration of the macrophages, okay. And over here you see there is so much, you see there is so dense infiltrate we can see in here, okay. So that is all about the LL type. Now there are two special conditions. Yes, we'll see about the two special conditions about the LL type. Now all the classical variants are done. Now let us go on further. That is the histoid leprosy. This is pretty easy, short topic. Histoid type. Yes, in this what is happening is the patient, yes, the patient was on a therapy, the Dapson therapy, but monotherapy, only one. Now the one we use multi-drug therapy, right? MDR, right? this was only one therapy, that is if we give a dapsone to the patient and the patient, yes, has a relapse following the dapsone. This is where there is new type of leprosy, that is a histoid type, and you see these firm pearly like structures, yes, which are shiny. Okay, we will see about that. We'll make our notes as well, but you just see the image. In whole of the 5 types of leprosy we did, from the determinant to the indeterminate and all of it, did we see something like this? It is no, right? This is a very classical condition which is seen in a relapse condition. Okay, all right, so you should know this. And it could also be because of dapsone resistance. Okay, and what it and how to describe this? What is the best way you would describe this? These are the dome shaped shiny papules, right? Simple. Definitely you see, like even in the when the person was trying to take a photo, yes, it's shining as well right now. So yeah, these are dome shaped which are shiny. Yes, and they are firm. Definitely we can see and feel in the image as well that they are firm. Okay, fine. Not the best way to make the diagnosis, but still. Okay, the next one, the first we just got completed with the histoid leprosy. The second one we have is 𝗲𝗵𝗵𝗴𝗺 leprosy. Histoid leprosy. The second one we have 𝗲𝗵𝗵𝗴𝗺 leprosy. 𝗲𝗵𝗵𝗴𝗺 leprosy means 𝗲𝗵𝗵 means beautiful, right? Why do we say beautiful? Is because in this type of leprosy there is loss of wrinkles. Yes, that is what we all desire, right? Loss of wrinkles, and we have that nice clear young face, with intact collagen and everything looking perfect right at this spot. Okay, all right, so there is loss of wrinkles. Definitely this patient did not inject him or herself with a lot of Botox. This is because of the leprosy. Yes, and it is most commonly it is seen in Mexico. Okay, we will come back to that, but first, this is no wrinkles. Okay, there is loss of wrinkles in this. This is a diffuse non-nodular form of leprosy. You see, this is most common in Mexico. You see right here in this patient, there's almost like such a clear skin, but still there is this is a type of leprosy known as 𝗲𝗵𝗵𝗴𝗺 leprosy. Okay, so now let us see about the nerve involvement. Okay, so before going on to the details, I just wanted to make this one point very clear. That is the point number 1. That is, there is in all the type of leprosy there is 100% involvement of nerve, not even 99.9, 100%. Okay, that is the reason even in the first type, the indeterminate type, we saw hypopigmentation, right? We saw hypopigmentation in that is the 100% nerve involvement which is there. Okay, now let us see, like if the ulnar nerve is involved. Yes, not only in this leprosy part, even in the other one, if the ulnar nerve, even if it is damaged, right? So we read something like a claw hand, we see something like a claw hand. Okay, if ulnar nerve and medial nerve are damaged, we see total claw hand completely. Okay, we'll see the images as well. Let us see right now. Okay, so this is just the ulnar nerve which is damaged. Yes, right, like this. And if this is ulnar plus median nerve that is damaged. Okay, how about this one? Can you comment on this? Definitely there is only one nerve which is going off in your head, that is the common peroneal nerve. That is the foot drop. Yes, so even in leprosy, if the common peroneal nerve is involved, there would be foot drop. Simple. Okay, so we covered up the first 3 points. Yes, this peripheral neuropathy. So this almost coincides with diabetic neuropathy. Yes, so what is happening in both the conditions, even though the etiologies are different, what is actually happening is the patient is not able to feel, in its peripheries. Yes, so he cannot feel, he does not have any sensation. So just in case if the person hits up any rough surface, and he for some reason he gets an injury on the foot for some reason, do you think the person will know? No, there is loss of sensation, This is the same findings we see in the diabetic neuropathy as well, right? Okay, these two conditions, even though they are different, but this part is same. Okay, all right. So you see there is this ulcer which is being formed over here. Yes, this ulcer which is formed is known as trophic ulcer. Yes, it is known as trophic ulcer. This is glove and stocking anesthesia. Yes, we just read about this before as well. So it is just the second time this word is coming up. That is about the glove and stocking anesthesia. So the patient is not able to feel something in the hands and in the legs. In diabetic nephropathy, the sensation in hands are there, quite there, but there is loss in the foot. The foot sensations are lost. Yes, so that is why we do write the 10 point. We take out our instrument and we see like, okay, fine. Tell me. We just ask the patient, right? Where do you feel the sensations? Where do you don't feel the sensations? So that we know what is the extent of the diabetes. Okay, fine. That is about the endocrinology part. We come on to the Hansen's disease right here. Yes, so these 4 images which are there. Yes, you see in this patient. Yes, that is the reason, usually when we see, just in case maybe you might have seen, the hawkers which are there, around the roadsides. First time I saw this patient, something like they had hands like this. I never really understood like what is actually happening, because I guess I was in just my school time, right? And I saw a hawker. They were like doing like this, and I asked my father, like, where are their fingers? Where are the fingers gone? And then he explained me the whole thing. I did not understood that well at that time. It is like such a long ago, but still. This is a finding which we can see, maybe even now, we can see these kind of patients, right? Across the road, yes, across the road I saw a hawker, he had leprosy. Okay, fine. And this is about the foot. You see this, the whole toe is gone, right? You see right here, you see right here, you see right here. Okay, fine. That is about that. So that is about the nerve involvement which is there, okay, in this image as well, you see. Yes, okay, all right. So that is about the nerve involvement. Now we'll shift our discussion to the cranial nerve involvement. Okay, what are the predispositions of having this disease, and what does it predisposes the patient to? Yes, so this is one answer, one question that we need to answer. Okay, fine. Let us start the discussions about the cranial nerve involvement. Okay, facial nerve is involved, that is the motor supply is the one which is most commonly involved. Okay, facial nerve. Okay, because of this there is paralysis of orbicularis oculi. Okay, if this is paralysis, so what's going to happen? Yes, so something known as lag of thalamus, it will take time, because the lid muscle, right, the lid muscle which is paralyzed. So but it could still close, the eyelids could still close because of the cranial nerve number 3. It's still working. That is the reason it closes, but there is something known as lag of thalamus. Okay, iridocyclitis is also, what is the other name for it? This is anterior uveitis, right? Iridocyclitis, also the another name is anterior uveitis. Okay, that is one thing that is we need to know about this, because this is paralysis of the facial nerve. The two conditions are being elicited, that is lag of thalamus and anterior uveitis. Okay, fine. In the BL and LL cases, we see in iris we see something called as iris pearls. Yes, we see something called as iris pearls. Okay, all right. And what are these? Are the microgranuloma, yes, which are deposited. Yes, microgranuloma which are deposited in the eyes. Okay, iris pearls, very classical thing, that we should remember. Okay, iris pearls. Definitely I will make a list about all the limitless hot words and hot topics. Yes, and we'll have a discussion about that as well. Fine, so that all of the information that we are reading, right, in this whole PDF is quite an extensive one. So I'll be making a summary out of it, and we can have a discussion about that as well. Okay. Yes, the facial nerve is involved, and the trigeminal nerve is also involved. If the trigeminal nerve is involved, there is decreased corneal sensations. Yes, Okay, there is decreased corneal sensation. So if this nerve is involved, we have 𝗵𝗵𝗵𝗵. If the trigeminal nerve is involved, we have decreased corneal sensations. What does these two things predispose the patient to? That is the question. It predisposes the patient to blindness, right? Okay, increased predisposition to blindness, because you see, the eye is open, the eyes are open, yes, the lid is not closing. If the lid is not closing, what is going to happen? It will be continuously exposed to the air, right? There will be dryness, yes, anterior uveitis, yes, it will be there. And moreover that, what's happening is, the person which should be able to sense like, oh no, there is so much of a dryness in my eyes, I am not able to close it. The person is not able to feel any sensation. He would be like, okay, no problem, everything is fine, life is good, But the thing is, his manifestations, his symptoms are not elicited. Yes, like if we check in the patient, we can see, but the patient would not know. This is the whole meaning is about. The patient would not know about this. Yes, that he is progressing towards blindness because of involvement of these two nerves at the same time. Okay, I hope you get this concept very clearly. Okay, and this point is also very important, that about the iris pulse which is there. Okay, all right. The facial lesions have a very high risk of Leprae reactions. We'll read about Leprae reactions a lot, but this is just one point we have to remember, that is about the facial lesions. Yes, Leprae reaction type 1 or type 2. We'll see which lesion goes in which. Okay. How about the systemic involvement about this disease? Systemic involvement, yes, we read about the skin. This is kind of summary. I just wanted to add this one point. So this whole thing is made up. Skin, we saw some hypopigmented patches, nodules, we saw nerves were thickened, and there was sensory loss as well, And eyes, iritis, keratitis, 𝗵𝗵𝗵𝗵𝗵, we saw. Bones, there is reabsorption and there are deformities. Testes, atrophy and infertility. In liver, there is mild hepatomegaly, but this one is the most important one. In kidney, right? In kidney, we have glomerulonephritis, and there is secondary amyloidosis. So all of this you will just remember just like that, but this one you have to make some effort, to remember it separately. That is glomerulonephritis and amyloidosis. Okay, that is one thing I want you to remember in this. And in the blood, we'll have the patient will have anemia and the increased ESR, because there is increased inflammation in the blood, right? Because there is increased inflammation, there is increased ESR. And how about the nasal thing? Nasal crusting, and there will be saddle nose, because there is nasal septal perforation. Okay, there is almost loss of the whole nasal area, right? Okay, so that was all about the systemic involvement, right? But and the next topic over here we have is the Leprae reactions. All right, so we'll be learning about that in a moment. But before that, I just want to get a little bit off course and introduce you to this movie. I don't know, maybe many of us have seen this movie or not. This is a fantastic movie. It's called, the name is Motorcycle Diaries, the Motorcycle Diaries. All right, so in this movie, what happens is, these are two friends, and the one who is riding the bike, this guy is a doctor, and his friend, he is a chemist. Yeah, he's a chemist, and they just happen to go on a bike ride. Yes, and they leave everything. They be like, okay, fine, we'll go there and we'll see all the Cuba and everything. Okay, and they go back, and this is the one of the things they desire to see. All right. And definitely, like we love I love motorcycles. Yes, the bike rides and everything, it just gives such a good sense of freedom. Yes, we go on, maybe it is a day ride, maybe it is a night ride, we go on with our friends. I have endless memories of me and my friends. I miss him right now. Definitely more bike rides ahead. So yeah, this is just about it. But the reason is not about I want to the reason I'm talking about this is not because I just want to share my hobby or something. The reason is that in this movie there is a link about leprosy. All right, so that is a part about it. Okay, so what happens is, this doctor, the whole movie revolves around the fact that he has to go to a certain doctor, yes, a certain person who is doing research, and in that he is treating the leprosy patients. okay, the Hansen's disease leprosy patients. Okay, so that is about that, and the way he has acted in this movie, and this is a true story, okay, and the way the whole thing goes, it is pretty good, and you really feel that he is a real doctor. He's a real doctor, and he really has sympathy for his patients, and he really want to do something about it. Okay, so that is all about the motorcycle diary. So definitely, if anybody is enthusiastic about motorcycles, and definitely we can catch up and talk with an endless discussion about it. Alright, so getting back to our topic, that is the Leprae reaction. Okay, so Leprae reaction, if you guys remember, what was this? Yes, first of all, this is the reaction which body is doing. The body immunity is acting against the offending agent. Okay, so that is what it says over here, that acute inflammatory response in leprosy due to sudden changes in immune response, causing flare-up lesions and flare-up of the lesions and the inflammation in the nerve damage. Okay, alright, so that is about it. We did this before as well, that what are the Leprae reactions? These are the reactions which are done by the body to the offending agent. Okay, and there are two types of reactions. Yes, so fine, but the basis of it, we already discussed the details, right? What it is going to be about and everything. The main crux has already been discussed. But over here, what I've done is, this is a whole comparison format. We'll read about type 1 and type 2 Leprae reaction. Okay, and which type of hypersensitivity is that we'll be discussing. We'll be discussing about the pathogenesis and the clinical features and the systemic manifestations as well. Alright, so that is going to be like a bit of overview about it, and so let's start with this. So the first one is, I'm not the one who is supposed to answer this question, because definitely we have been through elaborated detail about it. So what type of immunity kicks in type 1 Leprae reaction? Tell me. So what is it? It is Th1 or Th2? Yes, it is Th1, right? Th1 T cell mediated. Okay, it is a Th1 T cell mediated. Okay, so that is about the type 1. Okay, and how about the type 2? If it is Th1, this is Th2. Okay, alright, but I hope you guys remember when we just did the first page. If in our notes, you can go back and see this concept is explained to you over there as well. Okay, but more to that is going to come in a minute. Let me just write that down. This is Th2. Yes, this is B cell. Okay, so type 1 is T cell, type 2 is B cell. Okay, so if anybody know, like, what are the functions of B cell, what are the functions of T cell, if they know, well and good. If not, this is the pathogenesis. Okay, simple as that. But before that, let us discuss one rule over here, right? So which type of hypersensitivity reaction is that? So this is a very famous question, which has always been asked, and I don't think so it's a very difficult one to get it right every single time. What is the question is, which type of hypersensitivity reaction is type 1 Leprae reaction? Which type of hypersensitivity reaction is type 2 Leprae reaction? So now if we learn it, right, so probably you might be thinking, okay, fine, it's just pretty easy. But once you have all those 19 subjects, running on in the top of your mind, and somebody shoots up a question, so there are chances that we could get it wrong, right? But what are we going to do is, at this time, what you will do is, you will just remember this one rule. What is that rule? This rule is about rule of 5. If you remember this rule of 5, so what's going to happen is, you will never get this question wrong. Okay, what is the rule of 5? So you see, the type 1 is hypersensitivity reaction type 4, okay, and type 2 is hypersensitivity reaction type 3. So 1 plus 4 is how much? It's 5, right? So 1 plus 4 is 5, and 2 plus 3 is how much? Is 5, right? So if anybody tells you that, okay, which is type 3 hypersensitivity reaction, Leprae 1 or Leprae 2, so what is gonna be? You're just gonna add 2 to it, so it's type 2. Okay, in hypersensitivity reaction type 4, somebody asks you that, okay, fine, which is the type of Leprae reaction is seen in this? You be just, okay, fine, I know that this is about the rule of 5. We just apply it here and we get it right every single time. Alright, so that is the key thing you have to remember over here. Okay, what did we just learn about? We just learned about rule of 5. Okay, all right. So this is pretty important. This goes for both of these. Okay, rule of 5. Okay, fine. So one thing is out of the table now. We discuss about the type and we discuss about the hypersensitivity reaction. How about the pathogenesis? Definitely you know a few points about it because we have discussed about it earlier as well. Okay, so what are these points? I just want to get you a brief overview about the pathology part. Yes, so usually we don't read this part too much, right? So but today I just want to clear that once and for all for lifetime. What is it? Th1, this is the one we discussed already, right? So Th1, the T cell in Leprae reaction type 1, what are they doing is they are activating the interleukin 2 and interferon gamma. Alright, so what do these stimulate? Yes, these stimulate and they are activate these cells. Which are these cells they activate? They are the memory cells, right? The memory T cells are being activated. The memory T cells. Okay, alright, so what's going to happen is if the offending agents come for the first time, alright, so they will have this memory, right? Okay, fine. So whenever this comes, so we have to have this sort of reaction. Yes, so what happens if the offending agents come for the next time? So do you think the response will be slow or faster? It's going to be faster, right? Definitely it's going to be faster. Okay, this when the antigen appears again, right? So the memory the Th1 cell they rapidly activate, yes, and they secrete what? They secrete interferon gamma. Okay, they secrete interferon gamma, interleukin 2 and TNF beta. What does these do is these cytokines they go in and they destroy the tissues. Okay, you get this point correct? The tissue damage happens, the tissue destruction happens because of this mayhem. Okay, was this necessary or is this body overreacting to something? It is body's overreaction, right? Okay, tissue destruction, the reaction is over exaggerated. Okay, all right, and over this you see one of the thing that we have to understand is over here there will be no systemic manifestation. No systemic manifestation. The tissue destruction is happening only on the superficial surface. There are no organ involvement in this. Okay, all right, you got it. There are no organ involvement in this. Fine, that is one thing that we have to know about it. Fine. So how about the other one, the Th2, the type 2, the Th2 one? What happens over there is Th2, what it does is it activates the B cells. Yes, it promotes B cells. And what does these B cells do is in return, yes, they produce what? They produce antibody which leads to the formation of immune complexes. Okay, fine. Immune complexes are formed in this. Okay, that is the reason you see this will be the basis of the next name, right? That the type 2 Leprae reaction are also being called as erythema nodosum leprosum, ENL. These nodules we see, these are the immune complex deposition which are these. Okay, did you get it? Did you get that concept right? Okay, fine. That is very important to learn. Like we read about the pathology, we read about the clinical manifestation, we exactly know what's happening. Okay, so type 1 reaction, it is which type of hypersensitivity? Type 4. Type 2 Leprae reaction, which is type of hypersensitivity? Type 3. Which cells are involved? B cells. Which Th1 and Th2? Th2, right? Th2 stimulate what? It stimulates B cells, it forms the immune complexes, and return we have these immune complexes. Yes, so we see something known as the nodules. Okay, all right, you got it. Did you get that part correct? So I hope you get it right, because no worries if you didn't, we'll do it everything once again when we revise the whole chapter. Okay, so at the very end what I'm going to do is once we are done with the whole Leprae reaction thing, we'll go to our first page and we'll have a quick revision of the Hansen's disease once and for all. Okay, okay, fine. So let us go on to the next topic. Next point we have over here, that is the involvement. Yes, so which type of leprosy, according to the Ridley-Joplin classification, fall under type 1, fall under type 2. Okay, so in type 1 we have what? Any guesses? Are you thinking about TT type, or which type are you thinking about? Yes, so it's going to be the BT type, BB type, and BL type. And the BL type is the most severe one, right? Borderline lepromatous is the most severe one because it lies in the middle. It shows the feature of both extents. Okay, all right. And how about the type 2 Leprae reaction? We have more over of LL type. L type more shows more of the type 2 Leprae reactions. Okay, more than BL type. Okay, TT does not show any. Why? Because the features are not that pronounced yet. Okay, all right, fine. Two concepts over here. We have something called as upgradation reaction and downgradation reaction. Okay, if you understand the vocabulary, you can understand the reaction. As simple as that. Upgradation reaction is something when the body's immunity is increasing. So the patient, he would be traveling from a worst pole to like a good pole to be. Yes, so what is the bad pole to be is the LL pole. What is a good pole to be is the TT pole. So if the patient is giving a good response to the medical intervention, definitely is going to shoot up and will reach and there will be an upgradation reaction to TT level. How about the downgradation reaction? That is the LL level. If the person is not responding well, person is not showing a very good response to the medical treatment, or he is not having a treatment altogether, there will be downgradation reaction. It will be LL type. Okay, it's just gonna like slide down. We'll have LL type. All right, that is one thing we should know about. Pretty simple, right? So nothing complicated in that. And immune complex deposition, we read about this already. Fine. Over here we have about this. We go on to the next point, right? These are the clinical features. So these are the ones which are most important. Yes, these are the things which will be elicited in the patient, right? Obviously, because it's clinical features. Okay, all right. So what do you think about the type 1 Leprae reaction? What do you think? Like what would be the involvement? Any guesses? Any hints? Yes. So what's going to happen is we will have only cutaneous manifestation, no systemic manifestation. Okay, that there are no systemic inflammation, no fever at all. Okay, that is one thing. Fine. So what is this point about? I mentioned over here. What is this point about? Yes. So lesions, right? So existing lesions can be severe, and that can be extremely severe. There can be severe neuritis, but this is a special form of the type 1 Leprae reaction we see. Yes, what is the special form? This is called as a ภิ𝗟𝗏 leprosy. ภิ𝗟𝗏 leprosy. Okay, we have images about that as well. Okay, so because of this, what happens is the reaction is so severe that it ulcerates the skin. There is ulcers in the skin because of the reaction. Can you imagine it? Yes, just because of one reaction. Yes, just because of one reaction is type 4. Yes, hypersensitivity. What is happening is it is so severe it causes ulcer. That form of leprosy is called as ภิ𝗟𝗏 leprosy. ภิ𝗟𝗏 leprosy. Okay. All right. So that is one another type we just learn about, that if the reaction is too severe, it ulcerates the skin, and that is where we end up having the ภิ𝗟𝗏 leprosy. Okay. So let us just go ahead and see the images about it as well. So this is how it looks like. All right. Fine. Okay. How about the counterpart we have in the type 2 Leprae reaction, right? So in this, in the type 1, I told like they are only going to be the skin manifestation, right? In the type 2, what's going to happen is we'll have systemic manifestation. And what else we are going to have? We will have fever. Okay, we will have fever, and all the system involvement will be there. Like what? Hepatitis, arthralgia, and other system involvement are also going to be there. And also we will see something called as what? Because of the immune complex deposition, what did we see in the skin? What would you name that? The lesions, what you will call it? You will call it as nodules, right? Nodules. So what do we see? We see what? Tell me. In type 1, type 2, the presentation is totally different. Type 1, there was no fever, there was no systemic involvement. Yes, but the only cutaneous manifestation was there. But it was so severe that it could ulcerate and cause another type of leprosy that is called as Leonine Leprosy. And in the type 2, what's happening is, you see, there is systemic involvement, there is fever in it, and because of the immune complex depositions, what's happening is we will have something called as the nodules. Okay, the erythematous nodules which is there. So that is one thing we have to remember about it. Okay, cool. So that is one. That is all about the clinical manifestation that we see. How about the treatment? The treatment more or less the same for both, but yeah, we see we have to use systemic steroids. They are the drug of choice for the type 1. Okay, systemic steroids, and we can also use NSAIDs as needed. And drug of choice for the type 2 is also systemic steroids. We can also give clofazimine and thalidomide. Okay, thalidomide is a teratogenic drug. So yes, it is not indicated in all of the conditions, only in specific ones. Okay, but this you should know that thalidomide is used. Okay, so why? Because of the MCQ options. If I frame up a question, I mention like what all drugs are used in what all drugs are used in Leprae reactions. So you will see thalidomide, and I put like these 3 options, and the 4th is this one. Okay, and I replace the one with any other drug which is not there. At that time, these options become important, even though you may not use it in the clinical practice, but still the examiner is concerned about this, that do you know or not that thalidomide is used, it is indicated, even though it is a very small spectrum where it is used, but still, do you know it or not? This is what makes a difference, right, in our knowledge. Yes, so whenever we read something, it has to be very crystal clear. Yes, just like we read about the pathogenesis part. Yes, this part, you see, I hope I did justice to it, because once you understand this, yes, because when I was doing about the Leprae reaction and stuff, when I read about it, I was under great confusion, like what it is, where are these reactions happening, even though I read a lot about it, I couldn't get to a conclusion until when I started reading again, and I went through all the textbooks and everything. Now I have a good understanding that okay, fine, I can answer every question very detailedly when I come forward to it. Okay, fine. So that is all about the Leprae reactions. Okay, now we'll see some different type of phenomena. Okay, some different type of phenomena and different type of leprosy you can see. This is called as a Lucio phenomena. Okay, Lucio phenomena. What is it? Let us see. Lucio phenomena is seen in Lucio leprosy. So nothing complicated in that. Yes, is seen in Lucio leprosy. Okay, so what is this? What is this about? This is a non-nodular form of leprosy. Okay, non-nodular form. Okay, form of leprosy we see. What's happening is there is severe ischemia. There is severe ischemia of the underlying skin. Okay, why do you think so? There would be ischemia. Yes, one of the reason it could be definitely there is obstruction of the blood vessels leading to ischemia. Yes, we know that. But what could cause that? Definitely he doesn't have an MI. Yeah, yes. So what could be the reason? What do you think? Yes, it could be because of vasculitis. Yes, don't you think so? It could be because of vasculitis, right? So vasculitis and what? And thrombosis. And thrombosis. Okay, alright, so that is the reasons for having Lucio phenomena. Okay, so what is Lucio phenomena? This is a non-nodular form of leprosy. Okay, this is what ulcerative neurotic lesions are seen. Okay, why is it happening? It is because of the ischemia, right? Ischemia is happening. What could be the reason? It is vasculitis and thrombosis. Okay, fine, that is the reason we have these ulcerations we see. Okay, very classical thing, the presentation. You see, you just zoom it in the image, and we'll come to the notes in a while. You see, how would you describe it? See, definitely there is ulceration. There's so much, gangrene which is formed. Yes, because of the pathology we just discussed. So what is happening over here is, how would you describe this? Don't you think these are like geometrical jagged, appearance we see? Yes, geometrical and jagged appearance. It is nothing is like smooth. There is nothing, no clear demarcation. You see, yes, nothing is very clear defined. There are serrated margins. Yes, you see the margins are not clear. They are serrated like this. This form, whenever we see, this is serrated margins. Okay, all right. So that is, these are the presentations about the Lucio phenomena. Okay, fine. How would you do the diagnosis? Now we have completed the whole spectrum of the leprosy, the Hansen's disease. Okay, now we'll just dive into the diagnosis part, the treatment part, the investigation part, the chemoprophylaxis part, the vaccines part. Everything is extremely important. We should know everything. Just like tuberculosis, we have to know everything about the Hansen's disease. Okay, because the understanding should be very clear, because the reason is it is also included in our national program, right? Okay, how about the diagnosis? How would you diagnose it? Tell me. If I give you a patient about leprosy, how would you diagnose it? What all things you have in mind? Yes, tell me. Do you think that just having one thing would be enough? We need to have a proper investigation. Yes, investigation also I have discussed one of it, which is important. I have discussed already. Yes, we read it in our first page. Okay, so now we'll discuss about it. But the thing is, I want to know, like, are you able to think or not? So first thing that I hope you have in your mind is the hypopigmented patch. This is where the whole story started. Okay, this is the hypopigmented patch. Alright, so that is one thing, the hypopigmented patch. Okay, how about the next one? What do you think could be in the hypopigmented patch? Do you think about what can you comment about the sensation? Will there be sensation, or will there not be sensation? If there is, in which form of TB, which form of leprosy there is sensation? Tell me. In the TT form, right? In the TT form. Okay, fine. The sensations are normal. Okay, alright. Did you get that one? That much correct? Okay, fine. Over here now we have what all different places we can go. Think about it. Yes, so we can have the nerve involvement. If you remember, yes, there was this granuloma formation, and then there was this nerve involvement. It was compressing the nerve. That is the reason what it was happening. We were having something called as hypopigmentation and the loss in the sensation of that particular area, right? Yeah, so there was compression on the nerve because of the granuloma. Okay, you got it? Fine. So this is thickened nerves. And about the SSS, yes, we did something called as SSS. What is this? Slit smear examination. Yes, this slit smear examinations we see. Yes, over here. What do you think? It should be positive or negative? It should be positive, right? Okay. If you say it is positive, just the next slide, we have a concept about like this examination. When can you say it is positive? When can you say it is negative? It is, and in which form of, if we take up a smear and we see some particular type of thing, when you will call it positive, when it is negative, there is a relation to that. Okay, we'll come to that in a minute. Just the next slide about it. And how can you comment about the skin biopsy? Yes, definitely we have to take biopsy to confirm the diagnosis. Yes, in case of pure neural Hansen's. Okay, in this what happens is the involvement is just only about the nerves. Okay, alright, fine. Now let us go on to the investigation part. Yes, investigation part, the first one I've kept is the SSS, the slit skin smear examination. Slit skin smear examination. Okay, so WHO it recommends 4 types. Okay, but the minimum is 3 types. Yes, from 3 places we have to take the sample. Okay, minimum 3 spots. Minimum 3 sites. Okay, so what are these sites? Tell me. If you remember, if I just give you one hint, you will remember you can answer the first blank. What is the first blank? That the Mycobacterium leprae, it likes to be in which kind of environment? So cold environment, right? So on the body, which is the cold environment? Yes, comparatively, when we read the first page, when we did the introduction, I told you, right? What are the nerves it prefers? What are the areas it prefers? It prefers the ear lobes, right? Ear lobules. Yes, so one ear side, one ear lobe. And how about the next one? And 2 active sites should be there. Okay, so one ear lobule and 2 active sites. The smear has to be collected. Okay, and 2 active. Okay, fine. How about the procedure? Yes, so we have to pinch or squeeze the ear lobule. Yes, make an incision and take out the sample, put it to the path lab. That's simple. Yes, so pinch, squeeze the ear lobule, make an incision, and collect the tissue fluid. That's it, right? Not much complicated. And what are the sites? Definitely ear lobule is there, right forehead, chin, left buttocks in the males, and the upper thigh in females. Okay, so these are the most preferred locations in it. Okay, but now it comes to the point, like when we say it positive, when we say it negative, when we say it is positive. Okay, what is the first one? When do we say it negative? Is when it is paucibacillary. Okay, now did you get the example right? When I discuss about paucibacillary. Okay, what does pauci mean? Pauci means less. Bacillary, bacilli, less bacilli. Even though it is less bacilli, we are putting it, we say it is negative, but there is bacilli. Did you get it? Okay, did you get that point correct? Because this will be the foundation of the treatment we will discuss once we're done with the investigation part. When we start with the drugs, the individual drug. Yes, so this will be important, the SSS examination, right? Okay, so when it is negative, what do we say? It is paucibacillary. If it is positive, when do we say it is positive? It is when it is multibacillary. Okay, so a lot of bacilli, when I seen there, multibacillary. Okay, so see, that is the reason, if you understand that, okay, fine, somebody could just stop the treatment here, that okay, fine, yeah, I did the treatment, the SSS was negative, fine, you go home happy. No, but the thing is, there is bacilli, even though it is less, we are concerned about it. Yeah, so there could be downgradation reaction. Yes or no? There could be downgradation reaction, right? So even though for paucibacillary treatment, yes, so now there are updates. There are updates regarding this particular thing. Okay, alright. I've included everything. I'll tell you what were the guidelines before, what are the new guidelines as well. Okay, I have the whole kit, the whole 28-day kit, right, of each and every MTD. I have included for the multibacillary, paucibacillary, children from 10 to 14, and everything I have included. All the images are there. So one by one we'll come and we'll see on to that. Okay, so please for now remember this. Okay. How about the staining, the AFV staining, right? When we stain the particular organism, right? Mycobacterium leprae, we stain the organism. So with this, if we see solid, right? We see solid growth. Yes, we see solid growth. There is a solid pattern. Yes, then the organism is alive. Okay. When we see a fragmented pattern, it is dead. okay, and also if you see any granules, it is also dead. Okay, alright. So why should you know this vocabulary: solid, fragmented, and granules? Okay, when we learn something about the index, okay, yes, the morphological index, we will learn about it in a while. So this is where this concept, this staining comes in. Okay, fine. So just tell me, if there is a patient, if a patient comes to me, okay, and I want to check its bacterial load, how much is the bacterial load? So what factor in this will be important for me? This, right, in the solid form. Yes, it will be important for me. If I know how much bacterial load is there, I will understand, how is the disease progressing or regressing. Okay, fine. Now if I want to check, in the patient, that okay, fine, if I'm giving a good treatment, everything is going on, the patient is, very compliant, is compliant with the medicine, everything is doing, he's doing fine. But now I want to check that is the medicine working well, are the medicine working well, is the patient responding to it? What I will check? I will check these aspects, right? So how much is the morphological index, bacterial index, right? So these indexes, they become important to check the progression, to check how the drug efficacy, to check whether the patient is responding or not, to check the viral load. This is where these concepts come into play. Okay, I am building a concept that I will be using later. The third investigation that we have is the Lepromatous test. So this we did before as well. Yes, so this is the same image, I had it in the first page. Yes, that is the Lepromatous test. Same as Mantoux test we do, this is Lepromatous test, but over here what we have to remember are the timings. Yes, the timings are very important. Yes, and each timing has a particular name to it. Okay, that is one thing that we have to be very careful about. So yes, this is an intradermal injection that we give to the patients, and to what, to assess the immunity, definitely, right? So how well the patient is responding to it. Yes, that is something you would do. Okay, it is a prognostic test, it is not a diagnostic test. Okay, and classification, it helps it why do we do it? It helps us in the classification of village opening classification, right? To place the patient where does the patient belong. Okay, but now coming on to this part, the reading part, this is the part that we should know, we should remember very very clearly. If the readings are taken within 48 hours, so this is Fernandez. Okay, Fernandez. And if the readings are taken in 3 to 4 weeks, so what it is? It is Mitsuda. Okay, Mitsuda. Fine. These are the two things that we have to remember. So what is it? It is Fernandez or Mitsuda. Okay, so I hope I am pronouncing them right. Okay, fine. So what do you think will be the better one? Definitely, like the one which is taking longer time, we will understand more about the body's immunity, right? The cell-mediated immunity which is there, we will be clearly understanding about that. So 3 to 4 weeks is the better one. Okay, fine. Now let's come on to the concepts. Yes, that is about the bacterial index and morphological index. Okay, fine. The AFB staining that we did was about this. Okay, this is the concept I just spoke to you about before starting the Lepromatous test. Okay, what is it? It checks the density of bacterial load. Okay, so if I want to check the density of bacterial load, okay, what all bacteria do I have to include? I'm giving you a moment to think and answer me correctly. Yes, and I also want to know the total bacillary load. Total bacillary load I want to know. So what I'll be taking into account is the live as well as dead, right? Because I want to know the total count. I did not mention you like anything else. I just mentioned the total bacillary load which is there in it. What are we going to do is this bacterial index. Yes, it includes the live plus the dead form. Okay, all right, live plus dead form. So if it is live plus dead form, so which all patterns will you see? Tell me, solid form or the fragmented form or the granular form or all right, we'll see all of it. Okay, if somebody has undergone a treatment. Yes, if somebody has undergone a treatment, so what do you think? This bacterial index will be positive or it will be negative? Definitely it will be positive, right? Why it will be positive? Is because we are also including the dead ones. Okay, because we are including the dead ones in the bacterial index, what is happening is it will be positive. Okay, even after the treatment. So this is a very important point that we have to remember. So if you know the concept, you know it properly. If you don't know, then probably we have to read again. Okay, fine. So it remains positive. After the treatment. Okay, cool. That is one thing. And also the scaling is based upon 0 to 6. 0 to 6 scaling which is there, and each individual has a particular set range of bacilli which is included in it, and with that we'll scale it up. Okay, but for now you just remember what is the bacterial index actually. Okay, fine. Why do we use it? It is positive or negative after the treatment, yes or no. Okay, coming up next is the morphological index. What do you think is going to be? Tell me. Morphological index, if I tell you that we only include the solid bacilli, so what am I interested in right now? I filtered out the dead ones because solid form was what? The life form. Yes? Yes? Now do you understand the acid-fast bacilli, the staining we did? The staining we did, do you understand it? That if I say solid, it means it is live. And if it is live, this is the one I am concerned about in morphological index. So we come back to our concepts. Okay, morphological index. Solid bacilli, indicator of what? Yes, this concept, indicator of what? Tell me. Indicator of efficacy and how well the treatment is going on, right? Efficacy, and about the drug resistance. Okay, fine. Okay, so we can definitely check out, right? So how well the patient is responding, is the patient, how well the drugs are responding. So about that, if you want to check which index will you check, bacterial index or morphological index? The morphological index, right? The morphological index includes what? The solid form. Okay, solid form is the life form. Okay, fine. So tell me, if I tell you that, okay, fine, solid form is a life form, will it remain positive throughout the life or not? Tell me. So it becomes negative after treatment, right? Are you getting the concept? It becomes negative after the treatment. Becomes negative. Okay, alright. As simple as that, it becomes negative after the treatment. Okay, it's pretty interesting, I would say. So two indexes we read about bacterial index and morphological index. The bacterial index includes dead and alive. Dead and alive. So that is the reason it is positive throughout, even after the treatment. And how about the morphological index? Morphological index is positive or negative after the treatment. It is negative. Why? Because it just includes the solid form, the life form, right? Done. That is all well said and done. Now we are done with the whole diagnosis part. Yes, we have done the investigation part. Okay, we saw what to do, what the WHO said. Yes, how to do the SSS, the concept behind it. Yes, so now what are we going to do is we will go on with the treatment aspect. Okay, alright, fine. This is the mainstay of the leprosy treatment. There was an update here. Yes, so this is that update. But before that, I want the first table which is there, right? We will elaborate that a bit. Okay, fine. This is the elaborated format. Okay, cool. So what do we see here? We see something called as paucibacillary, multibacillary. Okay, as simple as that. But the thing over here is, okay, fine. Even though I say you simple, like, okay, fine, paucibacillary, less bacilli, multibacillary, more bacilli, but how would you define it? Tell me. The definition is very important. So if a patient comes to you, my treatment is based upon this fact that if it is which type of leprosy I am seeing, what are the findings? So how will I define it? So this is where this part comes in, right? The number of skin lesions, yes, the S test we do, okay, that is important, okay. The sensations, yes, are important in it, okay, fine. So let us just see one by one what it is. So everything we have discussed now in the whole chapter, we discussed everything. Now I am just compressing everything in one spot. After this we will come to the drugs, okay, and the proper regimen that has to be followed with the drug dosages as well, and how to remember them. This is the main part, okay. We'll go on with the skin lesions. Yes, if skin lesions are 1 to 5, if skin lesions are 1 to 5, we'll say it is a paucibacillary one. If skin lesions are more than 5, we say it is multibacillary. Okay, more than 5 multibacillary. Earlier this was 6, now it is 5. Okay, alright. The nerve thickening. Okay, 0 to 1 it is there. Okay, if there is none or 1, we'll call it as paucibacillary. If it is more than 1, we call it multibacillary. Okay, the SSS test we did, yes, okay, split skin smear examination we did. This was, if it is negative, we send the patient home. What do? You see, this is where the concept comes in. This is where we did the previous part when we did this. Over here you see. Okay, that is the reason I explained you, took a moment over here to explain you that this is gonna come up in the next slide. Okay, that is the SSS part. If it is negative, it is paucibacillary. If it is positive, we say it is multibacillary. Okay, that is the point from this table. So I hope you understand this one point. Okay, now the duration of treatment. This is very important. Okay, the duration of treatment in paucibacillary is 6 months, multibacillary is 12 months. Okay, you got it? 6 months and 12 months. Very simple regarding this. Okay, so now what I'm going to do is, we will come on to this table. So what I'm going to do is, we'll just read this table along. Yes, and the part 1 is already done. We did it. We'll see it again, no worries. And after that, I have the kids photo I have, and I have a few questions about you regarding that. Okay, so if you listen this properly, definitely you can answer them right in the first go. Okay, so let's start. This is a revised classification as we see. Okay, paucibacillary, multibacillary, we just discussed the number of skin lesions, 1 to 5, more than 5. Okay, nerve involvement, no nerve involvement. Okay, or it can be 0 to 1. Okay, alright, 1 or more nerve is involved over here. Fine. The SSS test we did, it is absent or it is negative, it is paucibacillary. If it is present, it is positive, it is multibacillary. This part we did already. Coming on to the treatment regimen. Okay, now once you have the patient, you know which type I have, what is standing in front of me. Now I know it. Yes, now I'll just say, okay, are you an adult or you? Definitely we can know by the age. This much we know. We can know by the age if it is adult or child. Okay, for example, if the person is adult, okay, the person is adult, yes, and you have the SSS test was negative, yes, and it was the lesions, the hypopigmented lesions were only from 1 to 5, SSS test is negative, okay, and there was no nerve involvement. Okay, so we put it under paucibacillary. Okay, the treatment duration is also discussed. Yes, till here it is the same, that the table is the same we did discuss above. Okay, the duration would be 6 months. Paucibacillary 6 months, multibacillary 12 months. No new information. What new is this? Okay, the 3 drugs we have. These are what? Dapsone. What are these 3 drugs? Dapsone, clofazimine, and rifampicin. Okay, that is the mainstay of the MDR. Okay, alright, so what are we going to do with the adult? Rifampicin, yes, we will give 600 mg once a month. 600 mg. How about dapsone? We will give daily. Dapsone is daily, D for D. Dapsone is daily, D for D. Okay, for adult paucibacillary, yes, what are we giving? We are giving just 100 mg. Rifampicin was 600 mg once a month. 2 drugs are done. Clofazimine, which is there. Okay, what are we going to do is, we will use 300 mg once a month. 300 mg once a month and 50 mg daily. Okay, you got it right? If you just remember this set of micrograms, the dapsone is 100 mg daily in paucibacillary, and rifampicin is 600 mg, yes, once a month. Okay, we have two things done. Now we have the clofazamine. It is just 300 mg once a month, and we'll give 50 mg daily. Okay, 50 mg daily. If you remember this is the same. Simple. If you remember this part, this is the same. The difference is the duration. Okay, only the difference is about the duration. Okay, fine. Now if I have a paucibacillary children from 9 to 14, what I'm going to do is, we have to alter the medication, definitely, because the children, they cannot withstand so high doses, but the drugs remain the same. Okay, alright, fine. So if there is a children, if there is a child for have a paucibacillary one, it means that the duration will be 6 months. The duration of a paucibacillary is 6 months. Okay, but what about the dosages? The dapsone dosage is half. What did we give before? We gave 100 mg, now become 50 mg. Dapsone is half. Dapsone, it is daily. And how about clofazamine? Clofazamine, you see, if it was 300 before, now it is 150. Once a month, 150. And we will give 50 mg, yes, but daily or alternatively. Okay, 150 mg alternatively. Simple, no confusion. How about rifampicin? Yes, the one causing red urine. Yes, we will see about the side effects as well. How about this? This is 450 mg once a month. Okay, did you get it right? Did you get that right? Okay, so you only have to remember two set of dosages, very simple. Okay, and the duration, paucibacillary and multibacillary, simple as that. Okay, so children, yes, from 9 to 14 year, paucibacillary and multibacillary, the only difference would be about the duration, you see, and everything is the same. This and this are the same, this and this are the same, no confusion about it. Okay, alright, so we'll do it once again. Okay, we'll do it once again, and cool. So this is the table number 1 we see here, right? So what are we seeing over here is we have to decide whether it is multibacillary or paucibacillary. So what can we do? We can count the number of hypopigmentation. Yes, we can also see the skin, the nerve thickening. Yes, we can also do something called as SSS. Yes, skin split smear examination. These three things we'll do, and we'll come to a conclusion that whether it is paucibacillary or multibacillary. Okay. Once we have multibacillary, paucibacillary 1, so we have the duration correct in our head. What is the duration? In paucibacillary 1, the duration is about 6 months. In multibacillary 1, the duration is about 12 months. Maybe it is child, maybe it is adult, we don't care. The duration for paucibacillary 6, multibacillary 12. It's a must. How about the dosages? Yes, so what's going to happen is that there are three drugs, the dapsone, clofazamine and rifampicin. Okay. Now, if there is an adult of multibacillary, okay, definitely the treatment is going to be for 12 months. Rifampicin, how much dosages you will give? You will just give once a month 600 mg. We just start from here, 600 mg. Okay. Second one we give is the dapsone. Dapsone 100 mg daily. Dapsone daily. Okay. How about the clofazamine? Clofazamine, the third one, right? So what are we going to do is clofazamine just 300 mg. We'll give the first time, right? When we have the first encounter of the patient, once a month we'll give 300 mg, and he has to take how much? 50 mg he has to take daily. Okay, that is all about the adult version. How about the kids? How about the children? From 9 to 14, what do we do about that? Yes, the drug remains the same, everything remains the same. The duration of the paucibacillary and the multibacillary remain the same. What changes are the dosages? Okay, the dosages are changed over here. What do we have here is definitely we'll give rifampicin. How much? 450 once a month. Yes, right here we have 450 mg. Dapsone daily, yes, but how much? 50 mg. Clofazamine, yes, over there we were giving how much? 300. So now we have to give how much? 150 once a month. And how about the daily dose of clofazamine? Is going to be 50 mg, but daily or alternatively? Alternatively. For children it is alternatively. Okay, very simple thing to remember, not much. Once you go through it once or twice, it is very simple to remember. Okay, fine. So we have done all of that part very crystal clearly. Fine. What is this? Tell me. It is a 28-day kit, right? Over here we have. What is missing here? I just want to ask you this. Okay, what is missing here? What more information do I need? Yes, to start the treatment. Yes, this is like a retrograde question that I put up. Yes, fine. What is it? There is rifampicin I'm giving. Yes, first day I give day 1 it is 600 mg once a month I'll give up. Capsone first 28 days I'm giving up 100 mg. Yes, clofazamine day 1 300 and day 1 to 28 I'm giving half the dosage, that is 50 mg. What is happening over here is, what do I need more? What information do I need? Yes, the duration, right? I need the duration. Yes, so what do I need to do? I should have the proper the table number 1, right? The multibacillary paucibacillary one. So if I know that, I can start the duration, right? So fine, this is an adult dosages for, could be paucibacillary or could be multibacillary as well. Okay, fine. So over here we have a National Leprosy Eradication Program. So that is the logo about it. Yes, and everything we have very crisp guidelines right from them, and all the kits which are available, everything is provided by this. Okay, the National Leprosy Eradication Program, that is NEEP. Okay, we have to remember this logo is PSL question, right? Very important thing to remember the logo. Okay, fine. Now we go on about this. Yes, fine. Let us just take up the first one. Usually, this is the part which is, I don't know, for some reason we are scared about it. Yes, but there is nothing to be scared about. Once you know that those two tables, right, we just discuss about, there's nothing to be scared about. There's nothing to be, bogged down about it. And we know the updates. We read about everything. Yes, we know the details. Okay, so let me just take the first one. Okay, then we'll take up one by one all, and we'll see like are they old one or are they new ones. Yes, okay. MTD TB adult dosages. Adult dosages was the first one which was there. Yes, MTD TB is the first one. Okay, the multibacillary one. Okay, multibacillary multi-drug treatment adult dosages. So you see over here, these are the strips, which the patient receive. Yes, these are the strips, and this part is supervised part. This part they have to be taken in front of the doctor. All right, this is the supervised part. Yes, and this is the unsupervised that the patient has to take. The patient has to be compliant in this part. This is supervised, unsupervised. Point number 1 is very clear. Okay, but if the patient is supervised, what all drugs are we giving? What are these drugs? These 1, 2, 3, 4, 5, 6 drugs the patient is going to take at one time. What are these? Yes, first of all, we'll give rifampicin 600 mg. Yes. So what do you think the drugs are? Yes, now we discuss about the supervised and unsupervised part. Yes, so the top part is the one which is supervised. How about the unsupervised one? What is it? But before that, we'll see about the individual drugs which are there. Okay, so we should be able to identify them. Okay, so in the MDR, right? So in the first one, the adult variant. So we gave, what did we give to the adults? Yes, in the one go we have to give 6 tablets. Okay, but over here 3 drugs are there. Over here, what specific drugs are there in this one? What does it tell me? What do you think this is? The one right here. What is this? 2 tablets, I see. This is what? This is none other than rifampicin. Okay, this is rifampicin. Okay, and how about the next one? The three which are there on the top. What are these? These are the clofazamine. Okay, fine. And how about this one? This white tablet which is there. This is dapsone. Now talk about the dosages. Tell me the dosage, rifampicin dosage. 600 mg, right? We gave 600 mg to adult. Remember? How much duration for paucibacillary? 6 months. Yes, 6 months. Multibacillary? 12 months. Okay. This is rifampicin 300 mg. Clofazamine, we gave 300 mg. Yes, so each drug will be 100 mg. Dapsone 50, 100. How much? 100. So if this is 100, this is also 100? No. When we give the first dose, it is 100, but when we give the second dosage, it becomes half, it becomes 50. For adult, it is every day, yes, daily, dapsone daily. And for children's, what do we have? It is on alternate day, right? Alternate day. Okay. So that is all about the MDT, yes, which is there. So we just saw the strip, right, about the multibacillary one in the adult version. Okay, so now comment about this. What is this? Let us take the multibacillary one in children. Okay, so I want you to tell me which drugs are these. First of all, definitely there are only 3 drugs we just discussed, but tell me the dosages. Okay, so if you know this right, definitely there is no doubt that you will get the dosages wrong. Tell me, what is it? What are these two? What are these two? These are rifampicin, right? Rifampicin. We'll talk about the dosages in a minute. And how about these? What are these? What are these? These are clofazimine, right? This one is dapsone. Okay. All right. So how about the dosage of rifampicin? How much was the dosage we gave in adult? Tell me. 600, right? Adult was 600. Children is not 600. Children is 450. But how will you distribute 450 in 2 tablets? One has to be 300. Other has to be 150. Got it? How about the clofazimine? When we give to the adult variant, right? So we give how much? 300 mg. But in children, I told you their dosage is half, 150. So if the dosage is half, each tablet becomes 50 mg. Dapsone, how much? How much was dapsone? Tell me. 100? 150? 50? How much? How much was it? Dapsone is 50, right? Dapsone becomes 50 mg. Okay, dapsone. Okay. So now you know about the strips. Yes, and this is the supervised part. The upper part is the supervised part. The lower part is the non-supervised part. Okay. Fine. Alright, so we are done with 2 parts about here, that is the adult variant of the multibacillary one and the children variant of the multibacillary one. Multibacillary duration, please, ladies and gentlemen, 12 months. Paucibacillary, 6 months. Dosage of rifampicin in adults, 600 mg. Dosage of rifampicin in children, 450 mg. Yes, how about, can you comment about clofazimine in adult? It is how much? 300 mg. Okay, we'll give up 300 mg. Yes, stat we'll give up first. Okay, and the next one, what we will ask him to do is we'll ask him to take daily. Yes, daily 50 mg we will ask. And in children, clofazimine is 50 mg. Yes, alternate or daily, alternatively. Okay, all right. And in the initial, it will be how much? 150 mg. Yes, that is the reason these tablets are 50, which has to be given in just a single go. Okay, how about dapsone? Can you comment? Dapsone is 100 mg in adults. In children, it becomes 50 mg. Okay, all good, fine, life is set. Okay, so one thing that we have to learn about is we should not panic. Like, don't panic. Okay, don't panic regarding anything. We can learn, we can memorize, we can increase the vastness of our knowledge to any given extent. The only thing is we need to be willing to do it. Yes, once we take out that internal resistance, yes, ki bhai ye to nahi, we have to take out the internal resistance, then we are like through and through with it. Yes, and then it is not like syllabus out of the syllabus, and everything is like if it is there, I should know it. I will know it. I must know it. Yes, then the brain functions differently. We just reach like some another level. Yes, and that is all. Okay, fine. One question to you guys. Okay, fine. So over here we have about the paucibacillary one. This is the multi-drug therapy paucibacillary one for the adult variant. Okay, so I hope you can see this one. Yes, what is this? This is the supervised part, this is the unsupervised part. What are these drugs? Tell me. This is what? This is rifampicin. This is also rifampicin. This is dapsone. Okay, all good? Tell me, does everything look okay to you or not? Where is this? Yes. Where is this drug? This is the update. Okay, you got the update that you see over here. There was only rifampicin and dapsone. In the recent update, what did the Indian government? Yes, they added over here is that we will use clofazamine as well for the paucibacillary variant. This is what we discuss in the table. This is an old strip. This is not the new one. Did you get it right? Paucibacillary. This is an old strip which is here, which we see. So we should know the old ones, the new ones, everything we should know. We have to know everything about everything. You know, in we reading something through and through, we should know about it. Okay. Okay. So this is an old strip. Okay. How about this one? You see again, now you guys are sensitized about it. Now you guys know that there is one more to it, that is clofazamine. Yes, and in the new variant, in the new update, we have added clofazamine in the paucibacillary one, and we are taking up the duration is given by WHO. Okay, and everything is given by WHO. We have superimposed clofazamine in paucibacillary variant. Okay, so this is an old. Okay, so what I'll do is I will make a cross. Okay, so there's no confusion, no nothing. Yes, so this is correct, this one is right. Okay, this is still valid format. This is also still valid format. Okay, all right, so now I hope, usually, you know, we just see this one image, you know, we seen this one image and we are like this is the only medicine which is available, which is not true. It is not true. We should know everything. We should know everything. We are doctors. We should know everything. Okay. So I hope, you know, this discussion is very fruitful, very high yielding discussion. I know we have the luxury of time, and definitely I'm using it. Okay. How about the drugs in leprosy? Yes. So these are the 4 drugs which are being under the NEET program. Okay. But there are other drugs as well. So definitely we'll discuss other drugs, but before that we should know about the side effects which the patients can face. Yes, when we give something called as dapsone, which is a very potent drug, right? Dapsone is a sulfone drug. It inhibits dihydrofolic acid. Okay, what are the side effects? Side effects are the one, like, you know, the examiners are very keen about, something called as agranulocytosis. Okay, agranulocytosis. Okay, and we have? What else can we have? Tell me. We can have methemoglobinemia. Alright, and we'll have hepatitis. So a lot of hematological problems are there because of dapsone, that is agranulocytosis and methemoglobinemia. Okay, that is one thing. How about rifampicin? See, R for R, reddish orange secretions would be there. Rifampicin, you see, that is reddish orange secretion which is there. Okay, alright, that is extremely important. Okay, rifampicin. Okay, how about the clofazamine? The clofazamine, you know, there is definitely something called as hyperpigmentation. You see this patient. This is the example of clofazamine. This is hyperpigmentation. You see in this patient. Okay. All right. And also there is a concept, you know, in the next chapter we'll read about something called as fixed drug eruptions. Okay. This could be example of that. Okay, fixed drug eruptions. We'll read about that. No worries. But for now, these are hyperpigmentation caused by what? Clofazamine. Okay, what other thing it can do is it can cause something called as fish scale appearance. The skin could turn like fish scales. What is that condition called as? It's called as ichthyosis. Ichthyosis. Okay. There is also condition we read about 𝗖𝗵𝗵𝗴𝗺 vulgaris. Okay, we read about this condition as well, right? But this is not regarding that. It is the etiology is different. Even the presentation, the patient is same. The etiology is different. Okay. Ichthyosis. Okay. All right. Now we have this is the ichthyosis part. Okay. Alright, you see this fish scale appearance, and these two images are very standard images, these two, okay, commonly abused everywhere. Okay, fine. So how about the next one? This is ethionamide. We use ethionamide, and in fluoroquinolones we use ofloxacin. Ofloxacin is a very good drug. We also use in typhoid. Very good response. 400 mg 2 times, very good response. Ofloxacin. Clarithromycin we use, and we use tetracyclines as well. In tetracyclines we use minocycline. Okay, minocycline we use. Okay, fine. So we have that. So all the drugs are discussed in leprosy. All are done. Pretty much all are done. Okay. How about the vaccine? Do we have vaccine about it? Yes, we have vaccine. Yes. What is the name of the vaccine? The first vaccine which was there. This is an MW1. Okay, MW vaccine which is there. Yes, Mycobacterium vaccine which is there. Okay, and what is the strain we use? This was the one which was the previous one. Yes, so and over there, and then we use a particular strain. The strain name was what? MIP, Mycobacterium indicus prani. Yes, so MIP which is there. Yes, MIP, Mycobacterium indicus prani strain we use. Okay, so we have to one, and this was the one which was extracted in India. So that is where indicus comes in. Chemoprophylaxis. Chemoprophylaxis. What do we do to patients who are exposed to it? Okay, we would give a single dose of what? Dapsone? No, 𝗵𝗵𝗵𝗵. 600 mg. Yes, we would just give 600 mg single dose, and everything is being taken care about. Okay, so that was all about the Hansen's disease, right? So, but today what I'm going to do is I'm going to have a quick revision of the whole topic. Yes, I hope this was a very good discussion for you. But now what I'm going to do is we'll have very quick revision about everything. Okay, so what you guys should be doing is you guys should be just looking onto the notes and just go on with the input. Okay, so first up, what we started with, it was just this bacteria which was we read about it as a granulomatous disease. Yes, and the point about preference to cold areas. Yes, that is the reason there was something called as ear lobules. We see this primarily over here. That is the reason when we take up the split smear examination, right? So that is the reason why we took an incision from here and two other places. So tell me, how many places does WHO recommend? What are the minimum places? 3 locations, right? 3 locations. Okay, fine. What does it involve? Usually the nerves, deeper nerves or superficial one, the superficial one. Okay, so because it does not like to be in a very hot environment. Okay, incubation period 2 to 5 years. Yeah, 2 to 5 years. Generation time is about 11 to 13 years. Okay, we have something called as phenolic glycolipid, which is there. That is something which is on the surface of what? On the surface of bacillus, not on our surface. It is a bacillus surface. Okay, is it easy to grow? No. What do we use it? We use it on the fat bed of the 9-banded armadillo. Okay, stain, red and stain. Okay, red and stain we use. So tell me, in the AFB stain, right, what does the fragmented mean? Dead or alive? It means dead, right? Okay, fine. What are the two indexes? Yes, bacterial index and morphological index. Okay, fine. So I'll be keep on asking you questions when I'm doing the revision, but everything will be haphazard. The questions will be haphazard. So I just want to make you uncomfortable with the questions. Okay, how the Ridley-Jöping classification we saw. Okay, so how did we come to conclusion? We did something called as Lepromatous test. Yes, manifestation, the immunological status of the patient, the bacterial load, and the histopathological findings we saw in the patient. Okay, so that was the mainstay about the Ridley-Jöping classification. Is it which type is it? Is it the determinant type or indeterminate type? Indeterminate means what? Indeterminate means that the body has not yet decided what to do. So that is the indeterminate type, and that is the reason. So this is the indeterminate type. So indeterminate type is what? This becomes the limitation of what? Ridley-Joplin classification. Yes. So because the body has not decided what to do, so how can we know about it? So this is the indeterminate type. And what all things we read over here, these are the determinant type. Okay, you got it? Yes. What is the classification? TT, BT, BB, BL and LL. Okay. So TT, tell me, can you comment about the immunological status, about the immunity of the patient? Very good. LL, immunity, very bad. Okay. If somebody is going from TT to LL, upward reaction or downward reaction, it is a degradation reaction. Okay, it is a downward reaction. If a patient came to us from a lower stage, we giving a medical intervention. Okay, and the patient goes up, it goes to TT form. What is it? It is an upward reaction. Okay, so tell me the type of hypersensitivity in type 2 Leprae reaction. What is it? It is type 3. Alright, yes. Tell me about type 1 Leprae reaction. What is hypersensitivity type? It is type which one? In type 1 Leprae reaction, hypersensitivity is type 4. Yes. Okay. Tell me about the skin manifestation. Is it there in type 1 or 2? Type 1. Okay. Alright. Tell me about systemic involvement. Systemic involvement. In type 1 or type 2? Systemic involvement which is there? Yes, it is there in type 2, not in type 1. In type 1 only cutaneous manifestation. Okay. Yes. And we have something called as Leonine Leprosy, which is seen in type 1 or type 2? Type 1. Yes. Okay. Alright. Let us continue with our discussion. Some overview about the Hansen's disease. Okay. This is the one concept we read about in detail about. So if T cells are involved, it is Th1. If B cells are involved, it is Th2. B cells, what they will do? They will what? B cells, they will promote the production of antibodies. That is the reason we have something known as the immune complexes in the type 2 Leprae reaction, which is where the B cells come in. Okay. Alright. B cell. Okay. How about the T cell? The T cell is the Th1, B cell is the Th2. Okay. Fine. A T cell, the TT1, yes, these are two examples we saw, right? About TT1, this is the best immunity, yes, and this is the one which will have paucibacillary, less bacillary. Okay, paucibacillary duration, please, ladies and gentlemen. 12 months, 6 months, 18 months, 20 months, how much months? Paucibacillary is 6 months. Paucibacillary adult, how much? And multibacillary adult, how much? Paucibacillary is how much? 6 months. Could it be adult or children? Same. No need to confuse. I'm trying to confuse you, but don't get confused. Okay. Multibacillary, what is the duration? In children? 12 months. Yes, so the concept remains the same. Multibacillary 12 months, paucibacillary 6 months. Okay, simple. How about we read something called as foam cells. Yes, foam cells. What was it? Macrophages stimulated, eating, not able to eat, they're swollen up. We found something called as foam cells in it. Okay, this is multibacillary one. Okay, this one we just did it about it. And how about the presentation? Yes, how about the presentation of the leprosy? Something we see something called as hypopigmented patches, solitary, ill-defined patches, right? So fever there or not there? Depends, right? Depends, right? If it is type 1, type 2, you know, it depends. We cannot just say up like this. Okay, fine. Sensations? Sensations, how are the sensations? Tell me. They are normal, right? We're talking about the indeterminate type. Sensations are normal. Okay, alright. Pruritus is negative. Pruritus is negative. Okay, tell me about the scaling. Scaling is seen in what? Peripheral scaling. Peripheral scaling, central clustering is seen in what? Okay, you think about it. We go to the next one, that is a tuberculoid type. Okay, so over here we have, what I have done is, you know, we go on through it very quickly. I'll not go to much detail. So fine, there is nerve compression. That is the reason we have the manifestations like hypopigmented patches will be seen. Okay, and there will be loss of sensation. And TT is how many patches? 1 to 3 patches. Okay, and we see something called as 𝗧𝗲𝗹𝗵𝗿 in the TT variant. Okay, how to differentiate the hypopigmented patch? We discussed this already. Yes, so okay. How about the BT variant? Yes, so how many lesions do you see? How many lesions will be there? Yes, about 3 to 10, right? 3 to 10 lesions will be there. So we have something called as satellite lesions. Borderline, the BB one, that is the mid borderline one, right? So over here we have something called as inverted saucer appearance. Yes, inverted saucer appearance will be there. How about the BL variant, this borderline lepromatous variant? What do we see here? We see this asymmetrical, yes, almost. And what is the characteristic feature? The sensation are back to normal. Okay, that is one thing we see. This is called as what? downgradation reaction, because the granulomas are decreasing, the foam cells are increasing. Lepromatous leprosy, the worst type, right? We see everything. We see the Leonine Facies, the medarosis we see over here. All the manifestations we see which are there are seen over here. Okay, fine. The other TS2 one, we see the foam cells over here. You see a TS of the nerve. Okay, we see these lymphocytic infiltrations in the nerve. Okay, fine. Okay, perfectly symmetrical, no granular formation, no nerve compression. Okay, so the sensations are normal, sweats are normal. What do we see here is peripheral neuropathy. That is the reason we have glove and stocking appearance. Okay, glove and stocking anesthesia. Okay, cold areas, the earliest sign we see in the cold areas, right, where nasal stuffiness and epistaxis. This is the reason it becomes a mayhem in the community, because it just keeps on spreading. Yes, epistaxis and because of the nasal stuffiness. Yes, so it becomes a problem for the society. This is where the whole infection keeps on spreading. Okay, main source of infection in the community. Leonine Facies and medarosis. We see what is Leonine Facies is like tiger-like appearance, of the face, and medarosis means loss of eyelashes and eyebrow. Okay, this is what about it. And earlobe we see, this is a Buddha's ear, like a Buddha's ear. There are a lot of depositions, right, on the ear. So this is like a big pendulous ear it becomes. Okay, and then also there is nasal septal perforation. Okay, you see right here, nasal septal perforation as you see in this patient. Okay, and in the image also, right, we saw about the motorcycle diaries, the person who was standing in the window. If you zoom it in, there is, you can clearly see, in that patient there is nasal septal perforation. The nose is been totally deviated towards one side. Okay, how about the histopathological one? We saw something called as a clearing zone. Why do we see clearing zone? Is because they do not at some patches they do not infiltrate the dermis. Okay, you see dense zone, the clearing zone. Yes, the clearing zone. Over here you see there is mayhem, there is dense infiltrate. Over here there is nothing. This is called as a green zone. Okay, all right. How about the next variant? There are two special types of the Lepromatous leprosy. One is the historic type. What is it? It is seen in dapsone resistance. What do we see? We see the dome-shaped lesions which are there, right? The shiny ones which we see. How about the Lucio leprosy? This is the beautiful one, beautiful leprosy. Why do we call it beautiful? Is because there is no wrinkles. No wrinkles. Definitely, she did not go up and take a good session of Botox and fillers. She has something called as Lucio leprosy, most common in Mexico, right? Fine. How about the nerve involvement? We read about the nerve findings as well, right? So this is all about the nerve involvement, the common peroneal nerve foot drop which is there. So specific nerve involved, specific manifestation. We have claw hand, complete claw hand, which is there. Okay, all right, fine. How about the cranial nerve involvement? Yes, this involvement of this predisposes to what? Blindness, right? It predisposes to the blindness. Why? Because of the seventh nerve and because of the trigeminal nerve, the fifth one. Okay, what is happening is there is something called as paralysis to orbicular oculi. Yes, but so we will have something called as lag-ophthalmos and iridocyclitis, also known as anterior uveitis. Okay, fine. We can have deposits. Yes, that is they are called as what? Iris pulse. We have something called as iris pulse. Okay, trigeminal nerve, because of the involvement of this, yes, there is decrease in corneal sensation. You see, there is no corneal sensation. There is lag-ophthalmos. Yes, there is anterior uveitis. So the patient doesn't know that how worst problem he is in right now, because the nerves are involved. The sensations are gone. He is predisposed to blindness. Okay. We had some moments, some good moments about the motorcycle diaries. Yes, the next one we saw our Leprae reaction. We just did the Leprae reaction, so but still we will revise it. Leprae reaction type 1, type 2. What is happening in type 1 is there is hypersensitivity type 4. That the other part is hypersensitivity type 3. Okay, systemic involvement in type 2, not in type 1. Yes. Okay, we have systemic involvement and we have something called as Leonine leprosy which is there. Okay, fine. Treatment: systemic steroids also used. Thalidomide is also used, and clofazimine is also used in type 2. Some images, these are the nodules we see, right? That is the reason. There is another name for it, that is erythema nodosum leprosum. Okay, we read something about Lucio phenomena, which is an ulcerative form, right? There are ulcers because of what? Because of vasculitis and thrombosis. Okay, there is geographical appearance. You see, there is jagged, serrated appearance. You see, how will you diagnose? one of the three should be there, that is hypopigmented patch should be there, loss of sensation should be there. Yes, nerve should be thickened and positive SSS. Yes, that confirms the diagnosis. But one or more cardinal features should be there. Okay, that is very important. Yes, how about the investigation? We tell me about the investigation. SSS. Yes, what does this conclude us? This conclude us that the patient is having multibacillary or paucibacillary one. So negative would be paucibacillary, positive would be multibacillary. How about the next one? That is the AFB staining. We know about, like we can conclude about the bacterial index and the morphological index. Yes, when do we use morphological index? To calculate the efficacy of the drug. Okay, bacterial index is being used to see the bacterial load. Yes, bacterial load, it means that we are taking into account of the dead and the alive as well. Okay, we read something about a Lepromatous test. The durations are very important over here. That is, if you see within 2 hours, it is Fernandez. If you see within 3 to 4 hours, it is 𝗵𝗵𝗶𝗶𝗵. Okay, that is a very important. The names are very important over here. Okay, what do? We put the antigen in the dermal skin. Alright, fine. We just revised about the bacterial index and the morphological index, and the treatment aspect I'll go about it and we'll finish this off. But the paucibacillary and multibacillary, we saw it. Yes, this is the conclusion we'll make about we'll make when after doing the SSS, right? So how many hypopigmented makes a diagnosis about the paucibacillary? 1 to 5. Okay, more than 5 we will see in multibacillary one. Okay, and tell me about the nerve. Yes, if there are no involvement of nerve, it is what? It is paucibacillary, right? If it is more than one nerve is involved, it is multibacillary one. Okay, alright, simple as that. SSS negative, paucibacillary, SSS positive, multibacillary. Okay, tell me about this. This you should know, like you have to know. After my class, you cannot just afford to forget it. You know, you are doing a crime against me if you forget this part. Okay, fine. I'll lodge a complaint against you. No worry. Fine. So tell me the dose of rifampicin in adult variant of MDR. Tell me the dose of rifampicin in it. Tell me what is it? Yes. How much is 600 mg? Right? 600 mg we give. How much we give daily? Once in a month. Okay. How about tell me about the dapsone? How much do we give dapsone? I'm talking about adult variant. Yes. Who is multibacillary. Okay. Tell me what is it? It is about 100. Right? Dapsone is 100. Tell me about clofazimine. You should know this thing. Crisp, you should know this table should be in your mind. Tell me about clofazimine. How much are we giving clofazimine? 300 mg. Once a month. We'll give 300 mg, and then how much we will give daily? 50 mg. Right? 50 mg we'll give daily. Okay? Alright. And how about the dosages? How about dosages in children? It becomes half. But the rifampicin is 450 mg. Okay? Alright. This is very clear. This table is very important. We should know everything about it. And at the end, we read about these, so we know we can from now, like you can see the upper part is the supervised part. The patient has to take in front of you. The bottom part, like the bottom part over here, this is unsupervised part. The patient is responsible for his own well-being. Okay, all right. So this is about the children ones. Yes, from 10 to 14 years of age. What is the difference between the WHO guideline and the Indian guideline, which is there? Indian guideline included clofazimine in the paucibacillary variant. Okay, so this becomes dated or outdated. This one. We don't follow this, right? We have added clofazimine. Okay, alright. So about the drugs, just let us focus on the side effect. Okay, dapsone has agranulocytosis. Some hematological side effect would be there. Okay, and clofazimine, what it does is it leads to hyperpigmentation and ichthyosis. Ichthyosis is what? It is fish-like appearance of the skin. Okay, and how about the rifampicin? What does rifampicin do? It has reddish orange secretion. Reddish orange secretions are seen in it. Okay, and tell me about the last point is about the vaccines which are there. Yes, the vaccine. Just tell me about the strain. I'm happy. It is Mycobacterium indicus prani, right? MIP. Okay, and how would you do about the 𝗖𝗵𝗵𝗴𝗺 if somebody is exposed to the bacteria? You would just give dapsone. You would give rifampicin, right? Rifampicin 600 mg. We'll just administer. That would be about the 𝗖𝗵𝗵𝗴𝗺. Okay. So ladies and gentlemen, that is all about Hansen's disease. So I hope you could take a few points from this discussion, and it was a very fruitful one. So alright, so thank you so much for listening and giving me your time.